use.
It is indeed a golden opportunity to exchange ideas and open discussion on theme gynae-oncology. It is indeed a golden opportunity for each one of us to enrich and enlighten ourselves. Without further ado, let's dive into a promising schedule. As we all know that cervical cancer is caused by persistent infection with human papilloma virus. Cervical cancer is the fourth most common cancer in women globally, with around 660,000 new cases and around 350,000 deaths in 2023. The highest rate of cervical cancer incidence and mortality are in low and middle income countries. This reflects major inequities driven by lack of access to national HPV vaccination, cervical screening and treatment services.
I am delighted to introduce you the guest of speakers for today's event who warmly accepted our invitation to join us, Professor Sundari Nandiala ma'am and Professor Sayyida Amina Naz ma'am. Would like to call our first speaker of event, Professor Sundari Nandiala ma'am, who is a senior consultant of MS Ramaya Hospital and a retired professor and HOD of the same medical college. Ma'am, kindly come on the stage and enlighten all of us with your knowledge.
Here, I think about 1 or 2 years back, I think I had visited here twice. I had come here, and I was really amused and I was really taken back to know the interest among these people and the postgraduates here to learn the colposcopy and cervical cancer prevention. Anyway, this is one topic which is very close to my heart. Thanks for them again to call me to speak on the same topic, okay? Now, today's topic is cervical cancer prevention and what is the methods of screening for prevention. When we use the word screening, matlab, we don't have any symptoms for the person. She is not suffering from anything. But a healthy person, you screen them or you test them to see whether they have any problem. That is a problem because we are not able to convince the public for this. I'm all right. Why should I get any screening done? That is the first question they ask. But it is up to us to convince them saying that, yes, you will be all right. Even 10 years you will be all right once it starts. Only after the end of 10 years you will get the overt disease. By then it is too late for us. This is one cancer, please all of you remember, in the body which can be totally prevented, number one, which is caused by only a virus, number two. Okay, these are the specialities, and the organ is very accessible just to look at it by simple speculum examination. So these are all the specialities and an easy access to the organ, but still maximum cases we have and maximum deaths in India are all over the world. If you take deaths of cervical cancer, I think we top the list. 1/4 of the deaths of the cervical cancer are from India. 1/5 of the prevalence of cervical cancer is from India. This is what happened. So knowing that it is totally preventable disease, 2018, the World Health Organization said, I think World Health Organization, all of you know, this is the supreme body for the whole world, which manipulates and which gives the guidelines for all the health issues. So World Health Organization suddenly realized in 2018, they said, eliminate cervical cancer. This is what they said, elimination of cervical cancer is a global issue and which is within the reach of every country, they say. You have your own ways of doing a screening, but prevent cervical cancer is that. Now the question came, is it possible in India? Because 1/5 of the world burden we have as a cervical cancer, 1/4 of the world and 25% of the deaths of the cervical cancer are occurring from India. So are we able to do this? Is this the task? Yes. Lancet Oncology says way back in 2019 itself, if you start from today onwards trying to screen the woman, by 2079 you will be able to achieve this. Imagine. This is what the FIGO, this is a Federation of International Gynecology. they have taken a declaration in this. She is an Indian woman, okay, Neeraja Batla from Delhi, AIMS, and she is one of the very active members of this FIGO, and she is doing a lot of work on this. We are very proud of her. They gave a declaration saying that by 2030, we have to eliminate cervical cancer. How are we going to eliminate? This is the mantra slogan they have given. 90, 70, 90. Wherever we go, we are going to talk only 90, 70, 90. What is the meaning of this 90, 70, 90? 90% of the girls have to be vaccinated. Yeah, this is another important thing for the cancer is, so far we don't have vaccinations for preventing the cancer. This is again a specialty for cervical cancer. We have a vaccination to prevent the cervical cancer. So all the girls, we need to get the vaccination done. That is up to 15 years is ideal. I'm sorry. Now Indian government has made it, FIGO has made it about up to 20 years we can give the vaccine. Before that we used to say up to 15th year. Now up to 20th year we can give only one dose of vaccine can be given. That will be sufficient for all the girls. And then 70% of the women. Suppose if I have a population of 100 people, 70 of those eligible women should have had a screening. That's the other thing. And 90% of the screen positive women should have some sort of treatment. Okay? This is what the WHO has proposed. I'm sorry. Thank you. I'm so sorry. So this we have to follow. Every country has to follow. Australia said it has eliminated cervical cancer. What is the difference between elimination and eradication? Smallpox eradicated, we say. Cervical cancer, we don't use the word eradication, but elimination. Elimination is you can't completely take it away. So what is it? 4 per lakh. If we bring it down 4 per lakh, that is the elimination of the cervical cancer. So we have to achieve that. Our goal will be that now. And when you look at the statistics, it's very, very, very discouraging and disappointing. See that each state-wise, if you see, if you take Karnataka, just see, we have only 0.5% of the women are screened, where 70% of the women have to be screened. We have screened 0.5%. Now you see the Telangana and Andhra, see it is all in single digits we have. When do we achieve this? Every one of us have to have this, okay? Now how are we going to do this? There are 3 mantras for this. One is create awareness. Though WHO didn't say, WHO says that you give vaccination, you do screening. But the most important thing what I feel is and what I practice is awareness. You must tell the public. Mainly the public has to be given the awareness saying that it is a preventable cancer. Any lady who is sexually active can get this cancer. So please get something done for this. Get your children vaccinated and you get the screening done. If I ask in this audience, how many of them have got their vaccinations done, youngsters, and how many of the ladies have got their screening done? Okay, it's left to them. Okay, that's what we are in. Now, creating awareness is a marathon task. Yes, we do agree. But still in the past it is done in India. Best example is polio. We have eradicated polio. Why not? This is the way we have done it. The same way government has to take it up, but government is not taking it up yet. I hope this time the government may take it up. They promised that, Prime Minister had promised in his election this one that he will take it up cervical cancer as the primary thing for the next time if he wins. Now I don't know how they are going to do it. This is the way we have to do public. We must do as much as we can do the awareness for the public. Now why the prevention and early diagnosis? What is the reason why we have to prevent? You know it. It's always, now we practice almost in every disease. You talk about diabetes, you talk about hypertension, you talk about cancers, prevention rather than treatment. Before, when I was young like all of you, we used to say, downstage the cervical cancer. There used to be a word, then we used to ask them in exam, what do you mean by downstaging the cancer cervix? That means we used to say diagnose it early rather than third stage, diagnose it in stage 1 and 2 so that the cure is there for the patient. If it is third stage, okay, you give something, you have cured for that, how long? It will come back definitely. Is it not? Recurrences are common. So we used to say downstage. Now a little forward, we have come a step forward is we say prevent the cancer, not downstaging. So preventing the cancer is, it is easy. Suppose you have got a pre-malignant lesions. Very easy to treat them. It's just an outpatient treatment you give. It is cured for the patient. You don't need to have to bother about even a hysterectomy for her. And then it's a complete cure. You can assure her, yes, for the lifetime you have been cured. And you will have your full length of span of your life, comfortable. So once she gets an invasive cancer, can we be able to assure her that, yes, you are going to live your full span of life? No way. Recurrences are very common. Maybe 5 years, maybe 10 years. Recurrences are common. So that's the other thing. And then think of the cost for the family, for the nation. How many of the institutes have got a radiotherapy units? Any radiotherapy institute you go, the maximum cases are cervical cancer. Why? Because it is diagnosed late, because awareness is less. So the morbidity is of course nil. If you have a CIN2, you do thermal ablation, what is the morbidity for her? Nothing is there. So these are all the advantages. Now coming to the topic as such, screening methods. Now, why the guidelines of cervical cancer screening is keep changing? Because this is what right now what we need to do is this. Whom to screen? Method of screening, okay? If you have all the facilities, do a HPV DNA testing, which is very, very objective type of test, very sensitive test. His sensitivity is about 98%. Specificity, though it is little less, but sensitivity is pretty high. Any screening method, as all of you know as a postgraduate students and teachers, sensitivity is important for a screening test. Now if you don't have, and what I do in the villages is VIA is good enough. Okay. Now, what is the age of the woman? Targeted woman is 25 to 65 years. Okay. Then the starting age is 25 years. So before 25, let's not do it. We used to say it's a 30 years in India. But now the age is brought down to 25 years. Even in a low resource settings, you can start at 30 years. The frequency, if you use the pap smear, it's once in 3 years. If we use the HPV DNA test, it is once in 5 years. That is good. Maybe twice if you starts at about 30 years, every 5 years. Maybe in her whole lifetime up to 60 years, say how many times she has to get a screening done. It is nothing, it's so easy. The age to stop is 65 years, provided previously she has got the screening done regularly and those things are negative. Suppose she had gone a screening last 5 years and she was positive. So from that time onwards, she has to go for 20 years for a screening. Suppose all the time she was negative. Now the screening will be only for 5 years, up to 65 years, that's all. After that, we don't need to screen the woman. Follow-up is for 12 months. Any of the problems we had pre-malignant lesions, we have to follow them up after 12 months of it. As I said, screening for abnormal smears, it goes for 20 years, whatever be the age. If she is 50 and she got abnormal smears or abnormal and you have given some treatment for her, up to 70, she will go for the screening. Post-hysterectomy, if she had no problems previously, the cervix has been evaluated. That's one thing, please remember, when you send the patients for hysterectomy, they must have pap smear done. That should be negative so that after hysterectomy, we don't need to do any cervical cancer screening for those women. Okay? And then CIN hysterectomy specimen. Suppose you have done a hysterectomy without doing any pap test. And in the histopathology specimen comes as CIN 1 or 2. That woman has to go for again a screening of the Walt smear screening or HPV DNA test after 18 months again once. Now this is what we have the screening methods: screen and treat or screen, triage and treat. We'll come to that. What do you mean by this? Is what the government says for us in India, even WHO says, wherever the resource settings are very poor, for us resource poor places, we screen and treat at the same time. Suppose you have put an acetic acid and then see the cervix is abnormal, treat them then and there, because they may not come back to you. Remote villages where I work now, they won't come back. So you can do the screen and treat. That is one thing we can have. And for the women who are having a HIV, we don't do that. We have to do a screen, triage and treat. You take a HPV DNA as a primary screening test. If it is HPV DNA, start at 30th year. Why? See, we said previous slide, it is 25 years we start. But HPV DNA alone, if you are using as a screening test, start at 30 years. Because youngsters harbor HPV DNA. And they have a capacity to, the infection will resolve spontaneously in them. So unnecessarily we should not be screening at 20 years, 25 years. If you screen, they are HPV DNA positive, they get worried. All that is not necessary. At 30th year, if they don't resolve the infection, that means if the infection is persistent, those women can go for cervical cancer. That's why for HPV DNA, we use the age as 30 years, okay? And see, this is. I'm so sorry. That's what I was telling them, I'm not well. Maybe I thought I can manage. It looks like I can't. Okay. See, now the WHO says latest is just twice in a lifetime if a woman is screened is also adequate. If that is one at 35 years, one at 45 years, but this test would be a very, very precise test, that is HPV DNA test. That's all WHO urges everybody now. If you can't do once in 5 years, you can't do once in 3 years, at least do it twice in her lifetime. One at 35, one at 45, HPV DNA testing. If both are negative, you assure her that she's not going to get cervical cancer. That's what the latest recommendation by WHO. Now, what are the screening methods we have? There are a lot of methods are there. Conventional pap smear is there, and liquid-based cytology is there, VIA is there, and then other things, of course, the other things, HPV DNA is there. These automated things are coming up so that the cytologists are very less for us in India especially. So automated computer-assisted reading of the pap smears is come up, and that is very sensitive. They say still it is in the initial stages. Probably we may have to get them. Once it comes into, probably it will be much, much easier for us because the burden to cytologists will be much less. Okay. These are all the things what we know. Conventional smear and liquid-based cytology, VIA and HPV DNA are the ones which I am going to talk about it. Okay. This is the way we take it. This is the liquid-based cytology plus HPV. This is the pap smear, how you take. I think all of you know that. Then so many tests are there, which one we have to follow. Anyway, WHO says you go for the HPV DNA test. Each test has got its own merits and demerits. That's why it goes on changing every time. The screening methodology goes on changing. If you remember my first slide, why the protocol goes on changing? Because every time after few years, see, this pap smear used to be the gold standard for many, many decades. Entire world said they used to take pap smear and they have brought down the incidence of cervical cancer by 60%. The same pap smear today is going to be histological importance after some time. Okay? But still in countries like us, we are going to use only the pap smear now. Okay, it satisfies all the criteria of a screening method. What we used to say screening method is accessible, affordable, acceptable and easy, very non-invasive. So all these criteria pap smear will definitely has got, is it not? It satisfies all the criteria of a screening method. So it used to be very popular. As all of you know, it's very, compared to all other tests, it is inexpensive and it's a simple, very non-invasive and local method, And training is very, very easy. If I have to train all of you, it just takes a half a day for me to train you to take the smear and to smear it on a slide. Those things you have to learn, of course, but that will take maybe a half day, at the most 1 day. I can train you, is it not? So that's why it is very easy test. But if you look at the sensitivity, so the main thing is positive predictive and negative predictive value. If you take of the pap smear, see this, false positive rate is 5 to 10%, but most alarming thing is false negativity is 15 to 50%. This false negativity depends on, number one, the person who takes the smear, number two, the person who reads the smear. Fixing of the smear is very, very important. Okay, I took the smear, I'm asking the sister, get me the fixative. Sister said, oh, madam, this is not here, I'll get from the other room. She goes to the other room and tries to get the fixative for you, and by then the smear has dried up. And it will have a lot of artifacts, and you get a lot of false negativity there. So the fixing of the smear is how you take the smear. It should not be very thick, it should not be very thin, should be uniform. That is what the training you have to get. Okay? So once it is done, the blood should not be there in the smear. Many a time you scrape the cervix, entire thing will be bloody. If you people have done the smears, you know it. So how do I avoid the blood? Put a drop of saline on that RBC's float, gently put it off, and then probably you can fix the smear. So these are all the things which we have to learn, and of course we need to have a very good cytologist to give the proper report. That's why this is real difficult. See, ambiguous reports are 6.4% and inadequate specimen. Sometimes they say a specimen is inadequate because it has got a lot of mucus, lot of blood, so it becomes inadequate. Now what is the solution for this camp? Liquid-based cytology. This is the limitations, as you know. I told you. Now comes the solution is liquid-based cytology is the one. Autopap, as I told you, computer organized, but that is not very popular now among all of us, but liquid-based cytology is popular now. The liquid-based cytology improves the sensitivity of the thing, and it eliminates all the mucus, blood, everything, it gets eliminated. Only the cells are seen. So easy for the cytologist to read the cells, and probably the sensitivity, that means the accuracy will go up, false negativity will come down by that. Okay, this is the way it is. And see, for the conventional cytology, you need about 8,000 to 12,000 cells you need in the smear, whereas for the liquid-based cytology, you need only 5,000, the cells you need to see. Okay, now this is the way it looks. See, the right side of mine is the conventional, where the blood is there, mucus is there, cells are clumped. But here the liquid-based cytology, each cell is seen differently, so it is very easy for them to see the architecture of the cell and the changes in the cell, so the sensitivity increases. Having said that, the sensitivity increases for the low-grade lesions. If you take HSIL, high-grade lesion, the sensitivity is both the test, it is same. Okay? So, but this is little costlier right now, liquid-based cytology. Of course, in Bangalore, everybody uses now liquid-based cytology only. Now, this is a special training is needed for the cytologist also, how to take this, and then there will be some sort of changes in the cells because of the procedure what they do. That should be known to the cytologist. That's not for us the headache. Now, this is automated computer analysis, which we are not practicing, so we don't talk about it. Now coming to the HPV DNA test, all over the world it is recommended as the primary screening test. Okay. Now see, the problem is younger women have a high positive rate of HPV DNA. That's why we said after 30 you do HPV DNA test if we are doing it. Identifies the test identifies the infection which can be transitory also. See, HPV DNA at that time it is positive, it is positive. Whether it's a transitory infection or it is going to be the permanent infection, it will not say at that juncture. Maybe you have to repeat after few years and see if it is persisting, then you say it is persisting. 86.7% of the positive women did not develop cervical cancer. That's the beauty of it for us, but the test is, this is a problem. All positive women of HPV DNA will not get the cervical cancer. Only 20% of the 80% will resolve, 20% will have, out of the 20% will progress to HSIL or a cancer. Okay? So what happens, it leads to unnecessary anxiety for women. Oh, I'm HPV positive, maybe I'll get a cancer. There are incidences where I have seen people are going and getting a hysterectomy is done because they are just HPV DNA positive. That's one problem in India for us. Unnecessary intervention rates will increase, as I told you, and sometimes over treatment can happen. It's a very highly sensitive test for detecting the high-grade cervical disease. It has a low specificity, as I told you. It can be positive, but after some time the infection will resolve by itself. So the specificity is not high, but sensitivity is pretty high. So this is what they said, that the prevalence in India is Partha Basu, who is there with the WHO IARC. He is an authority on cervical cancer. He is from India, and a lot of studies are being done by them. And he says 36.4% are there with us. Now I find in the villages what I am doing is pretty high. HPV DNA positivity is pretty high. Now what do? Basic HPV DNA test you do, it is negative. 5 years after you can treat her. If it is positive, she needs to get we have to see the genotyping of HPV DNA. So HPV DNA, there are 7 strains which will cause the cervical cancer. They are called high grade strains. That is the 16, 18, 32, 35, 42, 55, 58, 52, 58. These are the 7 strains which will cause the cancer. So they are called high risk HPV DNA. Supposing that you have to get, if suppose she is positive HPV DNA, we have to get a genotyping done. If she is 16 and 18 positive, immediately that lady has to go for colposcopy, because 90% of the cervical cancer are caused by 16 and 18. So she has to go for a colposcopy and the biopsy. Suppose it is the other strains, 32, 33, 42, 52, 58, if she is positive, we can just watch them, we don't need to do them. But 33 is really a cause for vulval cancer, we say now. So this is the way it is, okay? Suppose primary HPV screening is type 16 and 18, we have to do directly colposcopy. If other types are there, we can do cytology for them. Suppose the cytology comes as positive, we do colposcopy. If it is negative, she will go for 5 years routine scanning. Okay, this is what it is. This is advantages, it's an objective test. No personnel is involved in this. I am not taken the smear properly. Our cytologist has not reported. He is very young cytologist, not reported properly. These things are eliminated because it's an objective test. It identifies 14 high risk, 7 actually what we have is 7 now. The test what we have, 7 high risk viruses it can identify. Subjective variations are eliminated. Categorize the woman into, that is important. It categorizes into high risk or a low risk. High risk women have to be under surveillance. We have to survey them very closely. Maybe after 1 year we repeat the HPV DNA and T, or we do straight away colposcopy. But if it's a low risk woman, it is once they are not positive for HPV, we can reassure her next 5 years you are not going to have any cancer as far as cervix is concerned. That much of assurance we can give them, that's an advantage. See the sensitivity and specificity, 94% is the sensitivity. Having said that, I have to give a caution, there are some cancer cervix, 10% of the cancer cervix are non-HPV DNA. Life is not easier for us, so also the medicine. Everywhere we have some clauses, everywhere some doubts we have. So now latest has come up is 10% of the cervical cancer is non-HPV DNA. My God, where do we go for that? So only thing answer for us is screening. We have to do the screening correctly. Okay, this can be used as a primary screening. Follow-up after the treatment of CIN, that is called test of cure. Once suppose CIN is there, you have treated a next follow-up is by only HPV DNA, that is advised, better. You can do, if it is not even VIA, we can do. But the test of cure is HPV DNA test. Suppose HPV DNA is not there, that means she doesn't get the cancer. Now one more thing at this juncture I would like to tell you, because we are talking about cervix, I am talking only about the cervix, but this HPV DNA can cause many other cancers in the body. Now the cause for concern is the male cancers, especially the penile cancer, and the anal cancer is coming up in a high way. Anal cancers are caused by HPV DNA alone. Penile cancers are caused by HPV DNA. In a lady, vaginal, vulval and cervical cancers are by HPV DNA, no doubt about it. Apart from that, both male and female, oral, oropharyngeal cancers are caused by HPV DNA. So this many cancer, that's why now the slogan is even boys also have to be given the vaccine. Not only the girls, boys also have to be given the vaccine, because these many cancers we can prevent in boys also. Now the people are coming forward getting their boys also vaccinated. But we promote for the girls right now because we are worried about the cervical cancer. But these are all the cancers which are caused by HPV DNA virus. Okay, limitations of HPV DNA, is there any limitations? Because worldwide it is used as a cancer. But this I put because I realize these facts. Test cannot predict the infection which will not resolve which results are persist. True, we don't know at the time we have done test. I may get resolved, I may get cured of this, doctor, because unfortunately there is no treatment for HPV infection per se. Like any viral, you don't have treatment for it, and what it causes you treat. Is it not? Same thing. If the virus causes the changes in the cervix, we are going to treat. But as per the infection itself, we have no cure for it. We don't have a medicine to cure the infection. That we have to remember. Can't detect the past infection or infection that is cleared. Suppose she had infection and cleared, right now she is negative. But we don't know. But that is not a problem, because if it is cleared, it may not cause, or if the infection was there and some changes have occurred already in the cells. So infection is the one, and morphological changes in the cervical cells is something different. Two entities it is. The positive HPV DNA doesn't equal to she has got a changes in the cervical cells. Please remember, postgraduates, if all of you are postgraduates, and some, I think your staff also are here, I came to know. So please remember that it is not equal to. Infection is there. But when the infection is there, whether it has caused the changes in the cells, whether the pre-malignant lesion already has been there in the cervix or not, we have to know only by doing the cytology or histopathology. Is it not? Okay, that's another thing. Then testing cannot detect abnormal changes in the cervix. That's what I said now. HPV negative cancers also I told you. Okay. And then the glandular lesions. Now we say even adenocarcinoma, squamous cell and adenocarcinoma, there are two types of cancer in cervix. All of you must be knowing it. Adenocarcinoma is also caused by, but it not 38% of adenocarcinomas are non-HPV. This also we should remember. Okay, so now what next? The woman has got HPV DNA positive and she comes and asks you, am I going to get cancer or not? Do you have an answer for that? Yes, we should. Okay, now coming back, I'll come back. Please keep the question in your mind. I'll come back to that. Now this is BIA. When there are absolutely no facilities for pap smear or HPV DNA, still don't say no to the woman, but just put acetic acid 5% on the cervix, wait for 1 minute and look at the cervix, see how it can look. Easily it glares at you if there is abnormality. White area, that's called aceto-white area. Okay, at a positivity, see, false positivity is high, but false negativity is less. But only problem here for us using as a screening. Yes, India has proposed it as a screening method for the population-based screening. But the problem is, post-menopausal women, this test is of no use. Because the transformation zone, if all of you know about it, the transformation zone would have migrated inside the canal. So this test cannot help post-menopausal women. Wherein again we have a lot of chances of cervical cancer for us in India, is it not? 60 years, 55 years. If I go to village, I work in villages for the last maybe 14 years I've been working in villages, so I know the women attain menopause very early there. Even 50 years they would have attained menopause. So such women really need the screening, but I can't use VIA because it would have migrated up the transformation zone. The entire thing occurs in the transformation zone. I think in the afternoon when we have the workshop, I'll tell you about it. What is a colposcope? Why? What do we look at in the colposcope? All that I'll tell you if the time permits. So this is what. Another thing is it needs a experience for the VIA to say whether it is abnormal or normal. To say that you need an experience. Everything which looks white may not be abnormal. So you need to have some sort of experience for that. And this is what, otherwise this is the best test. See the sensitivity, it is also about 80%. Now look at it, very interesting slide. Sensitivity and specificity of various tests if you take, these are all the tests right now we have. Pap smear is 75% sensitive and 98% specific. See LBC, same thing almost like, okay. HPV DNA, specificity and sensitivity is the same, almost like, say, VIA you look at it, same. That means to say, if you are experienced to look at and tell the acetovite areas whether it is abnormal and normal, even VIA is good enough to trace, to screen the woman. So we should never say, I don't have a facility, I'm not going to screen a woman. Any facility which is there, you can use it, okay. Okay. None of the screening tests will say which one will progress to, which one will regress. Because you know that CIN1, 80% of them will regress, CIN2, 50% will regress to normalcy, only 20% will progress, and only 1% of the CIN1 will progress, so CIN1 we don't treat, only CIN3. Now suppose she has got a CIN2, 20% will progress. Then she will ask, will I progress to cancer or not? Do we have an answer for her? That's a dilemma we have right now. Yes. Challenge is this. Now this is the challenge we have now. Now for that comes again one more test. See HPV virus if you take, it has got a capsid proteins and all these things, E6, E7, I am not going into the details of HPV virus as such. This is something called HPV E6, E7 or RNAs, okay. That is if you look at the structure of it, you will find, you will know about, okay. Capsid proteins L1, L2 and E2 to E7, E1 to E7, these are all the proteins what you have. This can be, E6 and E7 are the ones which will cause, they are the oncoproteins, viral oncoproteins are, these are the two. They are needed to be there in the cells for it to progress, the cells to progress into dysplasia and cancer. In short I am telling, okay. Now if this is done, if you can see that E6 and E7 is positive in her cervical cells, you can say these are the lesions which will progress to cancer. Now simpler than this is biomarker. This is the other biomarker which has come up. This is P16 and Ki67. Same pap smear, we can do this. See the same pap smear here. See this. You can see these cells, okay. In this cells, see you will see the red and brown cells and the red cells. Usually these are the P16 and Ki67 staining. Same pap smear what you have done, you do the staining of this, and in this if you have the both cells it is same smear. See P16 and Ki67 will not exist in the same smear in the same cell. It should not exist. If it is existing matlab, these are the cancerous cells, they are definitely going to go into a cancer, precancerous lesions. So now this is the answer for the question she asked, CIN2 whether it progresses or not. Yes, we have to tell her. So the only problem comes with CIN2 if you understand it. I hope you know all these things. See CIN1 we have left it off now, we don't treat it at all because it's only a viral infection, and as I told you 80% of them will resolve by itself, so we are not going to bother. After say 1 year or 2 years, 1 year, you again take a smear and see biopsy and see if it is CIN persisting, then you do some treatment, some ablation, some cryo or thermal ablation. Otherwise you don't need to bother. If it is CIN3, you know definitely it is going to progress to cancer. Very little, maybe 10 to 20% regresses, but the rest is progressing to cancer. Almost CIN3, before, when I was like all of you, we used to call it as carcinoma in situ. At that age, we all studied like that, and in younger days I have taught it when I am a lecturer, assistant professor and all. I taught it saying the carcinoma in situ. So carcinoma in situ means you have to do definitive treatment. Now that word carcinoma in situ is given up, instead of that we call it as CIN3. Okay, over the years I have changed my talk also. CIN3 now the terminology. That means what? Still it is carcinoma. That means there is definite potential for malignancy there. So that you are going to deal with. Only thing in between is CIN2. Either it progresses or it regresses. So to know that, you do this test. If it is positive, P6Ki67 is positive, you say, Amma, you are going to progress, so let us give some treatment for you. If it is negative, you put her as CIN1 and say, forget about it, come back after 2 years, I will look at you afterwards. Simple. See how the test says. So this is the limitation of HPV DNA. Once you have done HPV DNA, she is positive, she progresses or not. Then you do a smear and biopsy. And biopsy says CIN2. Again you have to do this test. This is the way it goes on. That's why I said in the beginning, no test is perfect. But something is better than nothing. This is what beautifully the cells have been depicted here. Okay? Dual staining it is called. When you have a dual staining, if both are positive, definitely that lady is going to progress for cancer. Okay, this is again same thing in a detailed way. This was, they said, now a lot of studies have come up. So now we know what is a perfect test. There are so many tests now. Which is the perfect state? You decide. Okay, now what says? Every intervention counts to eliminate cervical cancer. Every intervention. Look at the cervix. That itself there is no growth, cervix looks clean. Okay, even that is helpful. May not be. As a colposcopist, I say no. When I put it, it looks very clean. When I put acetic acid, the lesion comes up like this. My God, I say. I had recently, oh, it's only ectropion, I thought. Young lady, 50-year-old lady, day before, colposcopy. Oh, she's young, it's only 50 years. Erosion. So somebody would have said erosion, but some doctor, the patient is lucky. For the erosion, she has sent to me for a colposcope. Okay, I put acetic acid. Columnar epithelium is taking up acetic acid. I said, why? Anyway, okay, I'll do a biopsy. I put it as query glandular abnormality to be on the safe side. I don't want to put it as adenocarcinoma there. I put it as glandular abnormality and I gave a report. I put as adenocarcinoma in situ first. Then I change it because it will be alarming for the people. No. So I change it to glandular abnormality and send it. The biopsy report comes as adenocarcinoma in situ. I pat myself, but at the same time I feel bad for the patient. But anyway, it's very early. It is in situ adenocarcinoma I have diagnosed, which is very difficult sometime with the colposcope. So we could do it because over the years, this is a third case, the last 3-4 months I have diagnosed, and yesterday one more biopsy I have taken, that report is still awaited. So anything you do it with a real experience. I mean, you go on looking at the cervix itself is enough. You say this cervix looks normal, this cervix looks abnormal. So every intervention counts to bring down the cervical cancer incidence, especially in India. Cost effectiveness you have to think of. You don't say every patient I have to do HPV DNA. All or none phenomena is not there. Okay? You have got choices now, wide choices you have, and you have to choose what is suitable for women where you practice. That's all it is. WHO recommends its member countries to develop and integrate cervical cancer screening into their health system depending upon the local, social, cultural and economic context. So that we don't leave any woman not being screened. Whatever method is available, whatever method you know to do it, please do it, but do something so that we are at least one step towards elimination of cervix. It's a long journey for us in India, but still each day, each one of us put one step forwards. All steps together, we may be 10 steps ahead in each day. Thank you very much for listening to me. Okay, thanks a lot. How do I switch off this? How do I switch off this? Yeah, I'll make it end, okay. Now here, okay, that's it. Thank you. Next topic, shall I start? Or you are all bored? Treatment. We have done the screening and we have got the pre-malignant. CIN 1, 2, 3 are pre-malignant lesions. Because postgraduates here I say, now there is a last terminology, that is lower anogenital squamous lesions, it is called last lesion. That is entire lesions of the lower genital tract and the anus, everything together. There the terminology is given is last terminology. In that, again histopathology also, CIN 1, 2, 3, instead of that, they say same LSIL and HSIL. Okay? LSIL, HSIL. So, in the LSIL means it is equal to CIN 1, HSIL matlab it is equal to CIN 2 and 3. In that they give HSIL in the bracket favoring CIN 2 or favoring CIN 3. They will give that. Okay, that's what we have to see. Suppose the comes like that. I think I have spoken already about the treatment, only I will rush through the slides. We have seen CIN 1, 2, 3, what we have to do, what we need not do. Okay, now see this. Okay. This is a quiz for you people. It looks like this. There is an ectropion on this. Do we have to treat her or not? Okay. She is persistent white discharge. She has come. Pap smear is done. Colposcopy is done. Colposcopy looks like this. It is negative but ectropion. We don't need to treat her, or if she is symptomatic, you can do a cryoablation. Is it not? Okay, that's it. Management is, okay, is this necessary colposcopy? Yes. Before you do any treatment for ablative therapy for the ectropion, you have to do the colposcope, because we may be missing some lesion. As I told, columnar epithelial lesion, just now I told you adenocarcinoma diagnosed 2 cases recently. So, for that sake, you do colposcope, make sure that there is nothing, and then you do the cryocautery, or even a thermal ablation can be done in this patient. Okay, any ablative therapy you do the colposcope. Okay, ma'am. This is, I thought it may be interesting, instead of giving a lecture I show the pictures. See, CIN 1, 2, 3, when you are treating, before that you would have done a colposcope. Whatever screening method you have done, number 1, please remember, screening, depending on the screening method results, you are not going to treat any patient. That is only a screening method. You have to confirm that with some definitive diagnostic method. Definitive diagnostic method is histopathology. But please don't do blind cervical biopsies. It is given up, but still even in Bangalore they do practice. Okay, unfortunate it is. See, where do you take a biopsy, blind biopsy? The entire cervix lesion may be somewhere, you may be taking biopsy somewhere else and say it is negative. So there is no scope. If you don't have a colposcope, if you don't know how to do colposcope, at least put an acetic acid and see acetovate area, and that area you biopsy. Okay, we have done a biopsy now. For that means you have to have a colposcope. So I am just showing the colposcope pictures and the diagnosis and the treatment, so that I thought it will be interesting for you. Okay. Can we do thermal ablation for ectropion? Yes, you can do thermal ablation also, equally important. Now see this. Ask us, it comes as. Pap smear you have done, it comes as abnormal squamous cells of undetermined significance. What should we do? See, here they say a lot of options are there. Like CIN 2, when it comes, you don't know what to do, whether it goes or it comes down. Same thing, ask us whether it will progresses or it is not. So anything you want, you can do. Either you observe the patient for some time, after 1 year ask her to come back, or you want to do HPV DNA for her, or you want to do colposcopy, fine it is for her. Okay. So close surveillance after 1 year. Okay. Colposcopy, directed biopsy, because she was persistently this one, so biopsy is done for her. Now this is it. Colposcopy is done. And transformation zone, this all of you going to see in the afternoon. Then how should we manage her? How should you manage her? This is nothing. You don't need to worry about it. I am not going into the AICOG risk management protocol and all, I think it will be too much for you people. I'm not going to go for that now, okay? You have to assess her. Suppose her previous positive smear were there, or positive biopsy is there. Now you ask us, then you go for colposcopy. Previously nothing was there, or she has not taken at all a pap smear, first time she has come. Okay, you leave her for 1 year and ask her to come back after 1 year. That is what risk assessment of the patient. Okay, this is the risk categorization. Okay, developing CIN3 and CIN calculations. Treatment decision is decided depending upon the risk calculated. Now it is, app comes in your phones, you can download the app and put the patient's findings and the present screening method result on that, and it will calculate the risk and tell you. If the risk is less than 4, ask her to come back after 1 year. If the risk is more than 4, now you have to do something for her. That is, the app is there. Okay, that is by the ACOG, American College of Obstetrics and Gynecology. Factors considered in that is previous test results, present screening abnormalities, and then you put her age, everything. This is the way it is calculated. Risk is less than 4 or equal to 4, more than 4. So you go for the colposcopy or you go for the routine screening. This is what I don't think we'll go for this. Say the routine screening has come as LSIL, you have done a colposcopy, and in the colposcopy you see these white areas. Can you see that? And even lugal iodine, it is unstained areas. You have taken a biopsy there, it comes as CIN1. This is what you have to put it for when you do colposcopy. This is what you have to do. Sweet scoring has to be done. Okay, when you do sweet scoring, depending upon all the factors, see this. Okay, this is of the acetovite, about the acetovite, then the lesion, type of lesion, then iodine uptake. This is all I will tell you in the afternoon. Okay, once we do that colposcopy and biopsy is done, it comes as CIN1. Sweet score is nothing, it will be less than 4. What do you do for her? What is the management option for her? Anyone want to attempt? Yes? You will have, depends on the age, high risk factors, persistent of the lesion. If suppose she is persistent, after 1 year you call her. If the lesion is persisting, then you do ablation. 1 year you can leave her. Suppose she is infertile, don't do anything now. Don't touch the cervix at all until she has 1 child. But ask her to come for the surveillance. That's all it is, okay? This is the one. The FIGO recommendations. This is the same thing what we have spoken. It's given as a chart here, okay? Okay, now see and treat. Okay, now see and treat. What do you mean by see and treat here? You have seen the lesion. To treat it by ablation, here it's only ablation. See and treat is screen and treat. Sorry, screen and treat is in the, suppose you have done a camp, you have seen put acetic acid, you have seen a lesion there, and then and there you could do ablation. Can all the lesions I ablate? No, you have the limitation. See that. Lesion should be entirely visible on the ectocervix. Entire lesion should be located on the ectocervix without any vaginal or endocervical extension. Lesion can be adequately covered by your large probe of the cryoprobe. Now the thermal ablator is better by you can do a stepwise everywhere you go and touch. That is one advantage we have with the thermal ablators, and there is no suspicion of invasive cancer. These criteria if you fulfill, then and there you ablate the lesion, it's fine. She will be cured. Okay, that's a for CIN1, that too if it is persisting. Not immediately, you don't need to do first time. It is persisting twice, then we can do that. Okay, fine. Now see this. See this white lesion here. Big white lesion she has got. Cervix looks so normal here, but when you put acetic acid, see the lesion how it has come up. Now what has happened? It has come as HSIL. Okay, high grade lesion it has come as. Okay, type 3 transformation zone, HSIL it has come. Now what should we do next for her? What is the treatment? See, sweet score has come as 9. That means it's definitely a major lesion, not a minor lesion. Management is LEEP or cone excision. Cone when will you do? When it is extending the lesion into the cervical canal, you do a cold knife cone. Otherwise, the loops are available. You can do a LEEP excision for that. Okay, indications for LEEP excision, same thing. CIN3 and CIN2 with inadequate colposcopy, HSIL pap smear with inadequate colposcopy. Discrepancy between pap, colposcopy and biopsy reports. Whenever there is one case I had it recently. Then students were asking me, Madam, what do we do now? When there is discrepancy like this, best thing is Think of the major lesion, the severity of the lesion, you take it as positive and eliminate it. So you do a cone, that is diagnostic cone you can do. And the lesion extending into endocervical canal, then also you have to do a lip excision. Persistent CIN1 or CIN2 and recurrent lesions after ablative therapy. Suppose we have done CIN2, we have done the cryo. Again after 1 year you see she has again CIN2. Those things don't go for ablation, you remove that area. Understood, no, for us that is what it is. Contraindications are whenever invasive cancer is suspected, we are not going to do the lip alone as a treatment, okay. Lesion extending into cervical canal. There is a third type of lip it can be do. It is done by a really experienced people, but for us, we don't do, we go for a cone, cold knife cone. That's all it is, okay. Now this is, she is HPV positive and HSIL. Then what do we do? Thanks a lot, ma. Okay? Same lesion is here, see this, and see this lesion. This is again a green filter with acetic acid, okay, ma? So the entire lesion is seen. Now the sweet score is 10. That means it must be really a CIN3. See, it has come as CIN3. What will you do again? You must go only the excisional treatment. Either you do cone. Here you may ask me one question when it is carcinoma in situ or CIN3, why can't we do hysterectomy, simple hysterectomy if she is 50 years or 40 years? That may be your question. Please remember, any CIN3, we have to do either a lip or cone first and rule out micro-invasion. There is something called micro-invasive cancer. Carcinoma in situ matlab, basement membrane is not breached. I think all of you know the histology, pathology, I suppose. Basement membrane is intact. There it is sufficient if you do only the conservative treatment like cone or lip. But if the basement membrane is breached, you have to go for a radical hysterectomy for the patient. Otherwise, it is not the treatment. Treatment is insufficient. So probably any CIN3, we have to do a lip or a cone to make sure that there is no invasion, micro-invasion. If there is no micro-invasion, that itself acts as a treatment for her, provided your lip margins are free. Is it okay or is it too much for you people? I don't know how much to teach you people because... Any screening, any method, all the women. Yes, please. Looking healthy is not a criteria for it to be healthy. I told no. See these services, when I just put a calpo, it looks very healthy. When you put acetic acid, see, at least put acetic acid. Take a pap smear. Something you have to do. All women have to get it. Only exception is women who are not sexually active, because they don't get the HPV DNA virus. It is all transmitted from men to women, HPV DNA virus. So all women have to get screened once they are sexually active. I don't say married now, because a lot of girls are, there's no criteria that marriage now. They are sexually active. So I say sexually active women and girls, they have to get it. After 25 years, they must start their screening. Because now it is increasing HPV DNA, because multiple partners and very early sexual activity, a lot of things. So it is increasing actually HPV DNA infections. 80% of, believe me, 80% of youngsters are positive for HPV DNA. But only advantage is they clear it off by themselves. But doesn't mean that repeatedly if they have the same attitude and lifestyle, they will be repeatedly getting infected and somewhere they will get caught sometime. That's a problem. Okay. Now the biopsy is CIN3 now. So remember CIN3 First thing is we have to do some test, either a leap or a cone, depending upon, if it is inside the canal, the lesion is, we do cone. If it is entire lesion is on the ectocervix, like here, see that. You can see everything is on the ectocervix only. Here you see, it is just going into, but still you can see everything. So entire lesion is there. So you can do of the leap and send it for biopsy, ask for the margins. If the margins are free, that is the treatment, you don't need to give her any treatment. Then what do we do? After 1 year and after 18 months, we do the test of cure, I told you. That is HPV DNA test. If we don't have HPV DNA, do at least a pap smear after 1 year and then see that she has no abnormal cells. That is the treatment and follow-up we have to do, okay? Okay. Okay, this is the treatment for CIN 2 and 3. We can do this, okay. We spoke, same thing I have given here in a tabular form. That's all I think. We'll stop here. See again pap smear HSIL, see here the lesion. All the quadrant of the cervix. In the previous you have only one quadrant. Here see, all 4 quadrant of the cervix, the lesion is there, okay. You take multiple biopsies. When it is like this, you have to take multiple biopsies, not one single biopsy, so that we know the severity of the lesion, okay. Directed biopsy done. What is the sweet score here? Okay, sweet score has come as 7. So that means it must be a, see that. See, because it has come as AIN2, now P16 or KI67 estimation is done. Okay, it's like that. Now I think I'll stop here. That is the treatment for we'll stop it off here. Okay. That is the treatment for CIN. What we have learnt is don't treat the pap smear reports or any screening method reports you have, don't treat. You have to have a confirmation, either colposcopically directed biopsy or acetic acid and then the biopsy. Okay. After the biopsy confirmation, CIN1 we don't need to treat her. We keep her under close surveillance. CIN2 and 3, CIN2 we know. Yes, we can do ablative methods, but CIN3 always it is excisional method. That's all in simple way. How do we manage the pre-malignant lesions of the cervix? Thank you very much for giving the opportunity, and I'm very sorry for the interruptions in between. Okay.
I would like to call Dr. Professor Wajia Begum ma'am to present a token of gratitude to Professor Sundari ma'am.
I would like to call on next speaker for today's event, Professor Saida Amina Naz ma'am, who is a former chairperson of Department of Amraze Niswan from Ajmal Khatibia College, CME, Aligarh.
Ma'am, kindly come on stage and enlighten all of us with your knowledge.
Professor Saida Amina Naz, I was going to present the presentation on the topic concept of cervical cancer in Unani medicine. First of all, I would like to thank HOD Ilmul Qabalat wa Amraze Niswan, Professor Ismat Shamim, and my dear friend Dr. Wajiha, Professor Wajiha, and Dr. Kausar Sultana for their very for the invitation for this lecture in this CME program. So today I am going to talk on the concept of cervical cancer in general. In the morning session also you had the same topic, but she had covered almost everything about the cervical cancer. So in our system of medicine it is something different, and very simple description is given in the Unani system of medicine, and some drugs which are very effective are told for the treatment of any type of cancer. Actually, the cancer was not, in fact, clinically or scientifically proved that this is cancer and only these drugs can help. There was a concept that there is a swelling and it is firm in consistency, and any swelling, any such type of swelling in any organ was treated with almost by the same drugs. So in gynae also most of the drugs are given, which are given for the general cancers. So now, I would like to start. It's not going. I will be covering the following headings. First of all, introduction. Then what is the incidence, especially in India? What are the causes? The signs and symptoms, the Unani concept, and prevention, and then the management. Now about the introduction, cancer is a class of disease which is characterized by uncontrolled cell growth, which can invade and spread to distant sites of the body, which is called malignancy. There are over 100 different types of cancers, and it is classified by the type of cell that is initially affected. Although it is a preventable disease, but can have severe health consequences and leading cause of death worldwide. It is a preventable disease. ये इस बात से भी साबित होता है कि अब तो इसका अब नहीं बल्कि काफ़ी दिनों से काफ़ी सालों से इसका वैक्सीन भी डेवलप हो गया है. किसी डिजीज़ का अगर वैक्सीन डेवलप हो गया है इसका मतलब इट कैन बी प्रिवेंटेड and very easily if it has got some vaccine against any disease has got its vaccine developed, तो उसका मतलब है कि उस disease को आप बहुत simple है उसका vaccine लगाइए और disease से बच जाता है individual. Cervical cancer क्या है? It is a growth of cells that starts in the cervix. The cervix is lower part of the uterus, all of you know, that connects into the vagina. Cervical cancer is the second common female malignant tumor. After which disease? Breast cancer. Most of the females have the large number of patients are of breast cancer. Then second number is cervical cancer. The cervical cancer is the second common female malignant tumor globally, which seriously threatens females' health. It is one of the leading causes of cancer death among women over the past 30 years. Past 30 years इसलिए भी कह रहे हैं कि तब से डायग्नोसिस होना आसान हो गया. उससे पहले भी फीमेल्स की डेथ होती थी, उससे पहले भी फीमेल्स को कैंसर होता था, बट इट वाज नॉट इजीली डिटेक्टेड और डायग्नोस्ड बिकॉज ऑफ लैक ऑफ techniques and lack of facilities. The increasing proportion of the young women affected by cervical cancer has ranged from 10 to 40%. Now incidence. Every year approximately 500,000 new cases of cervix are reported globally, and 80% of which occur in developing countries like India, where the disease is also the leading cause of cancer related to death among women. India accounts for a large number, that is nearly 1/4 of the world's cervical cancer death. Although हमारी कंट्री जो है अब नंबर 1 पे आ गई पॉपुलेशन के हिसाब से, लेकिन इसमें जो इंसिडेंस आ रहा है 1/4 ऑफ द टोटल पॉपुलेशन ऑफ द वर्ल्ड. यानी कि ये समझ लीजिए आप कि दुनिया को अगर 4 हिस्सों में डिवाइड करेंगे तो एक हिस्से की पॉपुलेशन जो है वो इंडिया में अफेक्टेड होती है. Then in 2018, 96,922 cases were reported. This largely preventable disease is the second most common cause of cancer mortality among Indian women. Now what are the causes? Causes were described very elaborately in the previous session. The commonest causes HPV, ये इसकी types हैं, HPV 6, then HPV 11, 16 and 18. The main cause of cervical cancer is HPV. Various strains of human papilloma virus, also called HPV, play a role in causing most cervical cancers. It is common infection that is passed through the sexual contact. And when exposed to HPV, the body's immune system typically prevents the virus from doing harm. In a small percentage of people, however, the virus survives for years. This contributes to the process that causes some cervical cells to become cancer cells. Now, any disease has some major or minor risk factors. So in cases of cervical carcinoma, the risk factors are: number one, early childbirth. That is, if the female is given childbirth in very less age, 18 years, 20 years, the chances are more. Multiple sexual partners, more than one partners, having more number of children, that is multi-para women. Again, early marriage, the same thing. The family history or hereditary, that is, there must be some family history of carcinoma of any organ, either from the father's side or from the mother's side. It also contributes. If the mother has suffered or mother was a patient of cancer, then there are 50% chances of transferring that hereditarily into the daughters. अगर 2 daughters हैं तो उसमें से एक daughter को होना बहुत ज़्यादा chances हैं कि एक daughter तो affected होगी ही cancer से. Smoking, which has become very common these days. Females are, I read in some article that females smoke more than the male. I don't know how they have studied, but it's कोई कहीं तो study की होगी. तो females are very chronic smokers. इसके पीछे कुछ myths होते हैं. Some people have told कि pregnancy में it is very helpful, so backward women smoke because of that. Some women are told that it is very good treatment of flatulence. तो flatulence के treatment के लिए smoking शुरू कर देती हैं. It means कि कुछ बहाना चाहिए होता है smoking करने के लिए, and then they switch over to smoking, and smoking is becomes the cause of the carcinoma of any organ, including the cervix. Now, oral contraceptive pills also. All of you know that if the hormones are given for long term, like for 2 years, 3 years, 5 years, then definitely it will cause carcinoma in the postmenopausal age or just before menopausal age, because after the withdrawal of the therapy, the body becomes more prone to carcinoma. Then unprotected sex. That is also important factor, because once if the male partner is also affected by such kind of disease, or there is some local infective disease, he may transfer that disease to her female partner. And one important thing, I don't think it has been given much importance, but this study was done and it was found that in the females which are from the Muslim background, they are less affected. And the cause was found that the practice of circumcision in the male, that prevents the carcinoma of cervix also. It was a study done. It has been proved. So next slide. What are the signs and symptoms? The commonest symptom, and which is very common in so many diseases, that is vaginal bleeding. The surface of the cervix is very soft and tumors bleed easily. That is, the cervix has a tendency to bleed even on simple touch, or postcoital bleeding is there, or if you do any instrumentation, the patient starts bleeding. In fact, if a woman has new vaginal bleeding after menopause, the total chance of cervical cancer is about 30%. The chances of having cervical cancer definitely increase after the menopause. All of the cancers, any type of cancer is, and the patient is prone to cancer after 40-50 years of age. But cervical cancer is such a disease that it can happen in younger age patient also. Second is vaginal discharge. Vaginal discharge also is a very common complaint of the patients. In fact, I will say that 80% of the patients coming to the gynae complain of vaginal discharge. And vaginal discharge is not always pathological, it is physiological also. And it increases in the state of pregnancy also. So if the vaginal discharge is of normal type, the patient will never complain you of any other problem. But if the disease is there, she will definitely tell you that the vaginal discharge is associated with itching or bleeding or any such a problem. So white or often yellowish foul smelling discharge that may occur with particularly advanced or necrotic cancer. With more advanced disease, there can be general pelvic pain also. If the patient has gone into stage 2, then there will be pelvic pain and other problems also. And because the bladder is very much connected to the lower genital tract, the patient may also complain of urinary symptoms which are seen with advancing disease when the tumor invades into the vagina, and eventually there can be closure of the kidney's urinary discharge or drainage. What happens? The cervix becomes larger in size and it obstructs the urethra, and the patient starts developing the symptoms of retention of urine. In old age, you must have read in that the patient already having stress incontinence and dysuria, urgency. So all these symptoms are already present in the patients previously, and if the patient develops the carcinoma of the cervix, they become worse. And the patient is not able to correlate because she doesn't know what is she going through. She will tell that it is from last 1 year, but it has become worse for the last 1 month. Then you need to investigate the patient, look for the carcinoma of cervix, and get her investigations done to further confirmation of diagnosis. This is called uremia and the most common cause of death from the cervical cancer, because दोनों systems मिल गए हैं, अब patient की treatment करना भी मुश्किल हो जाता है, and infection के backflow होने की वजह से kidneys भी affected होती हैं and the patient has more chances of dying. In the initial stages, the patient may present with complaints of excessive tiredness, loss of appetite and distension of abdomen. Signs include the lymph gland enlargement in the groin or the collarbone on the left armpit, and advanced spread may give bone, liver, lung, bowel or brain abnormalities. So these problems are because of the miliary, or you can say the spread of the malignant cells into the other organs. Now, how can you prevent? The main important thing is screening. It is an important strategy in the global elimination of the cervical cancer. Until and unless you go for a screening, if you don't know which area of the globe is more affected or how they are affected, and then you cannot prevent the disease until and unless you know the risk factors. So you have to do the screening on the global level to find the strategies according to their needs. ऐसा नहीं है कि पेशेंट को प्रॉब्लम इंडिया में हो रही है और हम उसके ऊपर वो सारी स्ट्रैटेजीज, वो इन्वेस्टिगेशंस, वो ट्रीटमेंट देते हैं जो यूरोप कंट्रीज में हो रहे हैं, वो यहाँ पर उसको उतना इफेक्ट नहीं आएगा. इंडिया के पेशेंट्स को इंडियन कॉजेज़ के अकॉर्डिंग ही ट्रीट करना पड़ेगा आपको, है ना. तो ग्लोबल का मतलब यही है कि आजकल तो एक ट्रीटमेंट कहीं किसी कंट्री में पता चलता है तो इट बिकम्स वेरी इजीली अप्रोचेबल फॉर ईच एंड एवरी पर्सन ऑन द वर्ल्ड. इट्स जस्ट अ क्लिक अवे. आपने क्लिक किया एंड यू कैन नो कि इंडिया में क्या दिया जा रहा है, अमेरिका में क्या दे रहे हैं, कनाडा में क्या दे रहे हैं. तो इट्स वेरी इजी. तो यू हैव टू, देयरफॉर इट इज़ वेरी important that you have to do the screening according to the place where the patient is living and what is her lifestyle and what are the causes. While HPV vaccination aims to prevent cervical neoplasia by preventing HPV infection, screening aims to detect prevalent cervical precancerous lesions such as high-grade CIN and adenocarcinoma, and effectively treat them to prevent invasive cancer and decrease cervical cancer mortality rates. So HPV vaccination, अभी जो पार्लियामेंट सेशन हुआ था इस वाले इलेक्शन के बाद, रिजल्ट्स के बाद, उसमें कौन है वो मैडम सुधा मूर्ति, शी टॉक्ड अबाउट द कार्सिनोमा cervical cancer and she अप्रोच्ड एंड उन्होंने डिमांड किया कि इस वैक्सीनेशन को फ्री ऑफ कॉस्ट नहीं तो कम से कम हाफ रेट में दिया जाए ताकि फीमेल्स कैन गेट वैक्सीनेटेड एंड दिस स्प्रेडिंग डिजीज कैन बी stop from the quick spread in the whole world. So such strategies are required. तो ये पहले तो कंट्री के लेवल पे, नेशनल लेवल पे होना चाहिए कि भाई हमारी सरकार या हमारी गवर्नमेंट को ही चाहिए कि इस पर फोकस करे. और जो कि वैक्सीन आई थिंक इट इज़ ऑफ 1200 समथिंग, दे वांटेड इन हाफ द रेट, 500-600 की अगर लगेगी तो ज़्यादा फीमेल्स लगवा सकती हैं और ज़्यादा मोर्टेलिटी रेट को कंट्रोल किया जा सकता है. सो दैट वाज अ वेरी गुड सजेशन ऑफ दैट लेडी एंड इट वाज अप्रिशिएटेड अ लॉट. उसके बहुत सारे वीडियोज़ भी वायरल हुए. मैं इसमें डालना चाह रही थी बट इट वॉज नॉट कमिंग इन to the slides. It will therefore remain a priority for cervical cancer prevention for several decades. Several cervical screening strategies have been used effectively in varied settings, such as pap smear. In recent years, liquid-based cytology is very important, very commonly in use, and HPV testing and visual inspection with acetic acid. ये तीनों ही चीज़ें आप पहले वाले लेक्चर में आई थिंक बहुत अच्छे से डिटेल में जो वो, क्योंकि शी इज़ डूइंग इट प्रैक्टिकली, शी हैज़ टोल्ड एवरीथिंग अबाउट इट. तो हमारे यहाँ क्योंकि यूनानी में तो वैसे भी हिफ्ज़ मा तक़द्दुम पे बहुत ज़्यादा जोर दिया जाता है, पूरा एक सेक्शन है इसका, पूरा एक सब्जेक्ट पढ़ाया जाता है और उसके अकॉर्डिंग हम लोग यही कोशिश करते हैं कि बजाय इसके कि डिज़ीज़ को हम इलाज करें, मर्ज़ का इजाला करें, उससे पहले हम ये कोशिश तदाबीर इख्तियार कर लें कि जिससे कि वो मर्ज़ ही ना हो. और ये आपको कंसेप्ट आई थिंक यूनानी में ही मिलता है, और किसी पैथी में तो मैंने नहीं सुना. मिलता होता भी है तो बहुत कम उसके एस्पेक्ट्स होते हैं. हमारे यहाँ तो बाकायदा पूरा इसका एक सब्जेक्ट ही अलग है. The World Health Organization has called for a global initiative for elimination of cervical cancer as a public health problem by implementing 90%, 70% and 90% triple pillar intervention strategy before the year 2030. So this is because the latest advice of WHO, so you will see this in everybody's slides. In the morning session also she had described it very well. कि हमें क्या करना है, 90% of girls should be fully vaccinated with 2 doses of HPV by the age of 15 years. So we should try to catch each and every girl or female and get her vaccinated. Even कुछ फ़ोन भी आते हैं हम लोग के पास, बाहर की कंट्रीज़ में थोड़ी ज़्यादा अवेयरनेस है या क्या बात है कि फ़ोन आता है कि भाई क्या करना चाहिए, इस वैक्सीन को लेना चाहिए या नहीं लेना चाहिए. So I say yes, it is good to take the vaccine, but prevention in other ways is also very important. 70% of women is screened using a high performance screening test at the age of 35 and 45 years. यानी कि 70% हमें अचीव करना है ये टारगेट कि हर 35 से 45 ईयर्स ऑफ फीमेल के अंदर स्क्रीनिंग हो जाए. Then 90% of women detected with cervical lesions to receive treatment and care. अब जो बचेंगे उसमें से 70% का ही हो गया, तो जो 30% बचेंगे उनके 90% की बात हो रही है. उसमें आपको ये टारगेट करना पड़ेगा कि दे शुड रिसीव ट्रीटमेंट एंड केयर. Three prophylactic HPV vaccines are currently available for use from the age of 9 years. तो as early as 9 years पे आप ये वैक्सीन दे सकते हैं. A bivalent vaccine targeting HPV 16 and HPV 18, जो हमने शुरू में टाइप्स ऑफ वायरस दिखाए थे उसमें से इन वायरसेस पे ये ज़्यादा इफेक्टिव है. A quadrivalent vaccine targeting HPV 6 and HPV 2, 11 in addition to HPV 16 and HPV 18. तो दो तरह की वैक्सीन है, एक बाईवैलेंट जिसमें 2 मिक्स की जाती हैं और एक क्वाड्रीवैलेंट जिसमें 4 वैक्सीन मिक्स की जाती हैं. तो अकॉर्डिंगली अगर डायग्नोसिस हो गई है तो उसके अकॉर्डिंग आप दे सकते हैं डिपेंडिंग अपॉन द कॉजेटिव ऑर्गेनिज्म. एंड अ नॉन वैलेंट वैक्सीन टारगेटिंग HPV टाइप्स 31, 33, 45, 52 and 58 in addition to HPV 6, 11, 16 and 18. So this is the basic thing. If we have gone for preventive measures, so there will be less load on the government, on the doctors for treating the patients. Now, previously it was for only girls. Now it has been proposed that boys should also get the same vaccine. For girls and boys, it is 9 to 14 years, a 2-dose schedule, that is 0.5 ml and 0 and 0.5 ml at 0 and 6 and then at 12 months. That is, the second dose should be given 6 to 12 months after the first dose is given. Those aged 15 years and older and immunocompromised patients, irrespective of age, must receive 3 doses, that is 5 ml at 0, then 1 to 2, and then at 6 months. The route is IM, deep IM. So this I need not to be discussed in detail because that has already been discussed. इसमें सिर्फ 3 चीज़ें हैं important जो ध्यान में रखनी चाहिए हम लोगों को. Number 1 वो कहलाता है जो the carcinoma which is only confined to the cervix. Then 1A is the diagnosis which can be done by microscopy, and 1B is clinically visible lesions which are limited to the cervix. तो first वो stage वो है जिसमें आप सिर्फ microscopically देख सकते हैं. 1B वो stage है जिसमें lesions को आप naked eye से देख सकते हैं. Then the carcinoma invades beyond the uterus but not to the pelvic wall or to the lower third of the vagina. And it is without parametrial invasion, then it is second A stage. Second B is the stage in which the parametrial invasion is also there. ठीक है, ये 4 तरह से इसको हम डिवाइड कर सकते हैं जहन में एक सिंपल सी पिक्चर बनाने के लिए, वरना तो इसका स्टेज बाय स्टेज बहुत लंबा डिस्क्रिप्शन है. और बायोप्सी वहाँ ली जाती है जहाँ पर आप नेकेड आई से आपने डायग्नोज कर लिया एंड यू हैव कंफर्म विद द हेल्प ऑफ द कॉल्पोस्कोपी एंड यू नो दैट दिस लीजन मे बी precancerous or it has gone into cancerous stage, then you have to definitely do the biopsy to prove the carcinoma and its extent and for the proper treatment. Normal cervix देख रहे हैं आप. Second है early stage 1B cervical cancer जिसमें से cervix के lips आप देख रहे हैं, only the outer surface or you can say the mucous membrane is affected. Then the late stage 1B cervical cancer, when it has involved the interior of the cervix. Then the cancer is outside the cervix, that is into the parametrium also. Now what about the diagnosis? ये सब डिस्कस हो चुका है ना. Diagnosis of stage 1A, 1A2 is made on the microscopic examination by taking the cone biopsy. Cone biopsy, all of you know that we have to take a conical excision of the cervix, जिसमें कि larger जो जहाँ पे हमने lesion को diagnose किया है उसका हम major part लेके and taper it off so that the cervix is not you can say removed. If the patient is having one or no children, तो उसको अपनी reproductive life भी continue करनी है. So we need to consider those things also. So we have to take a very less amount of the cervix and go for the examination obtained by LEEP or cold knife colonization, which includes the entire lesion. Then the invasive is ultrasound computed tomography, that is CT, MRI, PET. All these are give you the specific information about the how deep is the invasion and what type of disease it is. Then for detection of nodal metastasis greater than 10 mm, PET and CT is more accurate than CT and MRI. So these are the investigations which are advanced investigations, and they keep on improving and going more, which can say specific and accurate, so you can take help of all these investigations. Now what is the management? Everybody knows that carcinoma listens to only the surgical intervention, है ना. ऐसी दवाएं बहुत कम होती हैं जो कि कैंसर को रिमूव कर सके, कि कैंसर डिसअपेयर हो जाए. ऐसा नहीं होता कि दवाओं से ही सिर्फ ठीक हो जाए. So surgery is suitable for early stages, the cervical colonization. Then simple hysterectomy or radical hysterectomy may be selected according to the stage of the disease and according to the need. The microinvasive cervical carcinoma FIGO stage 1A treatment is completed with cervical conization, जो अभी मैंने बताया कि हम कौन शेप में सर्विस को काट लेते हैं, and unless there is lymphovascular space invasion, अगर lymph glands involved नहीं है तब. In women who have completed childbearing or in elderly women, extrafacial hysterectomy may also be recommended. Any route can be chosen, that is, you can do either from the abdominal route, vaginal route, which are or very minimally invasive routes. And when LVSI is evident, pelvic lymphadenectomy should be considered along with extrafacial hysterectomy. Because the lymph glands play a large, very important role in spreading the disease to other organs. If fertility is desired, cervical conization with close follow-up will be adequate. You have to remove the lesion and then ask the patient for regular follow-ups. Then stage 1A2, since there is small risk of lymph node metastasis in these cases, pelvic lymphadenectomy is performed in addition to type B radical hysterectomy. Low risk cases में ये सब है. When the patient desires fertility, she may be offered choice of following cervical colonization with pelvic lymphadenectomy, which is open or minimally invasive surgery, or radical trachelectomy with pelvic lymphadenectomy done by abdominal or vaginal route. So it depends upon the stage of the patient, which treatment or which regimen you have to offer, and the patient has more survival rates. Post treatment follow up, ये सब आपको पता ही है. After fertility sparing surgery follow up with 3 monthly pap smear for 2 years. You have to ask the patient to get pap smear done. Then 6 monthly for next 3 years, and with normal follow up at 5 years. नॉर्मल है पेशेंट का तो 5 years के बाद भी बुला सकते हैं आप पेशेंट को. And other tests including imaging are not recommended routinely and may be performed if required. Invasive carcinoma. Surgical treatment is the preferred modality for the treatment of stage 1B1, 1B2 and 2A1 lesions. It would usually consist of type C radical hysterectomy with pelvic lymphadenectomy. सब वही है. Now we come to the Unani concept. यूनानी में तो इसका नाम ही सरतान रख दिया गया है. तो सरतान has been defined as a type of malignant and melanotic swelling which can occur anywhere in the body. Melanotic या melancholic जो भी आप कहिए. कौन सी खिल्त इसमें सौदा का जो है प्रोपोर्शन बढ़ जाता है, या जो सौदावी मिजाज लोग होते हैं उनके अंदर ये डिजीज ज़्यादा कॉमन होती है. The description of cancer in the Unani system of medicine can be tracked back to ancient times, 131 to 200 AD. Jalinus was the first to describe tumors including cancer in very systematic way. He approved Bukhara's basic theory of cancer, who mentioned excess of black bile as the cause of cancer. Ibn Sina and Razi described most types of cancer known at their time and suggested several treatments based on their belief that cancer is the result of excess of burned black bile in the affected tissue. तो ये जो lymph glands और lymph nodes की जो अभी आपने सब सुनी, वो यहीं से इसी तरह का concept था पहले भी. उसी चीज़ को आजकल हम describe कर देते हैं properly कि lymphadenectomy होनी चाहिए, because फिजियोलॉजी तो वही है, पैथोलॉजी तो वही है, सिर्फ बयान अंदाजे बयान अलग अलग है. सर्वाइकल कैंसर को कैसे डिस्क्राइब किया? डिस्क्रिप्शन ऑफ द सर्वाइकल कैंसर इज मेंशन इन द क्लासिकल यूनानी टेक्स्ट एज सरतान और रहम, जो कि कामिलुस सना, तिब्बे अकबरी, ज़खीरा ख़ाज़म शाही वगैरह में दिया हुआ है. राजी मेंशन इन हलावी दैट सरतान इज वर्मेसुल्ब ऑफ रहम, इट्स रूट्स और स्टोनी हार्ड. जो इसकी खास पहचान होती थी पहले ज़माने में, वो इस तरह से होती थी कि जैसे आजकल हम कह देते हैं फर्म, सॉफ्ट, सॉफ्ट टू फर्म, मोबाइल है या नहीं है, स्टोनी हार्ड है. तो जो स्टोनी हार्ड फर्मनेस होती थी, जो कि छूने पे लगता था जैसे पत्थर को छू रहे हैं, या नियरली उसकी जैसी हार्डनेस है, आप सॉफ्टनेस कहीं से कहीं तक नहीं मिल रही है, तो उस तरह की फर्म टिश्यू, फर्म स्वेलिंग्स को सरतान का नाम दे दिया जाता था। इट्स रूट आर स्टोनी हार्ड, रेडिश इन कलर, रेडिश नहीं बल्कि रेडिश ब्लैक इन कलर। व्हेन इट occurs on the cervix, it is associated with severe pain in lower abdomen and back and is difficult to palpate on examination, and the lesion may be ulcerated और नॉन अल्सरेटेड। वही सारे सिम्टम्स हैं जो आज भी बताए जाते हैं कि आप अगर उसे छुएंगे तो अल्सर होगा, अल्सर होगा तो ब्लीडिंग होगी, और ये हार्ड होता है और पेनफुल भी होता है, एंड इट इज़ डिफ़िकल्ट टू, मतलब डिफ्रेंशिएट करना भी मुश्किल होता है। आप देख रहे हैं, सुबह मैं बता रही थी मैडम, कॉल्पोस्कोपी में देखने में तो बिल्कुल लीजन लगता ही नहीं कि कुछ है, जैसे ही आप आयोडीन अप्लाई करते हैं वो सारा खुल के सामने आ जाता है कि दिस इज़ द लीजन एंड दिस इज़ द नॉर्मल सरफेस। तो वो चीज़ें, ये चीज़ें उस वक्त क्योंकि अवेलेबल नहीं थी, या ये कहिए कि इस पर बहुत ज़्यादा ध्यान नहीं दिया गया, तब ये सब चीज़ें मेंशन नहीं है, लेकिन बात वही कही जा रही है कि इसका जो स्ट्रक्चर है वो फर्म होता है, and it is difficult to palpate and diagnose. The causes of cervical cancer are either Vermehar or Vermefalgamuni and Vermesulb of Rahm, or accumulation of Khilte Sauda. Usul Ilaj or Ilaj. The principles of treatment of sartan in Unani medicine is mainly emphasized on to prevent the collection of soda via vein section of rage basilic followed by rage safin. तो दो रोगों का फसद बताया गया है। फसद वेन सेक्शन अभी भी अब दोबारा से ये प्रैक्टिस में आ गया है, क्योंकि मेन जो कॉज है यहाँ पे जो बताया जा रहा है वो यही है, कलेक्शन ऑफ इम्प्योर सौदा कह लीजिए आप, या कंसंट्रेशन ऑफ द सौदा और उसका ब्लॉकेज हो जाना, यानी कि लिम्फ नोड्स के जरिए उसका एक्सपल्शन नहीं होता है, वो ड्रेन आउट नहीं होता है, एक ही जगह जमा हो जाता है। जब कोई चीज़ स्टैग्नेंट हो जाती है, रुक जाती है, तो फिर उसमें इन्फेक्शन होने के चांसेस बढ़ जाते हैं, उसमें जो मवाद होता है उसके सड़ने के, और दूसरी उसमें एबनॉर्मल पैथोलॉजिकल प्रॉपर्टीज़ डेवलप होनी शुरू जो हो जाती हैं, चाहे वो पैथोजेंस की वजह से हो रही हो या किसी और वजह से हो रही हो। The use of मुसीलात सौदा for excretion of the सौदा, यूज़ ऑफ लैक्सेटिव मुलयन अद्विया दी जाती हैं, मुहल्लिल दी जाती हैं ताकि सूजन कम हो जाए, और कुछ डाइटरी रेजिमेंट्स भी होते हैं। डाइट पे इसलिए ज़्यादा ध्यान दिया जाता है, जो कि आजकल इलाज भी तदबीर वाले मैनेज करते हैं, कवर करते हैं, क्योंकि ग़िज़ा से बीमारियों पर भी बहुत असर पड़ता है। जैसे कि अगर कोई सर्द मिजाज इंसान है, वो ठंडी चीज़ें खाएगा तो वो जल्दी बीमार पड़ेगा, इन कंपैरिजन टू अगर हार मिजाज वाला इंसान है, वो सर्दी ठंडी चीज़ें खाएगा तो उतनी जल्दी बीमार नहीं पड़ेगा। तो एक तो इंडिविजुअल के मिजाज पर डिपेंड करता है, दूसरा ये कि ये मर्ज़ जो है ये एक हार किस्म का मर्ज़ है, तो इसलिए हार नहीं बल्कि व्हाट यू कॉल, जिसमें सूखापन और मतलब हार याबिस है, तो उस तरह की चीज़ों को अवॉइड करना चाहिए, यानी कि उस तरह की डाइट्स लेनी चाहिए जिसमें इस तरह की क्वालिटी ना हो। अगर आपने ऐसी ग़िज़ाएँ भी लेनी शुरू कर दी तो उससे मर्ज़ का बहुत ज़्यादा तेज़ी से डेवलपमेंट होता है। दैन द लोकल यूज़ ऑफ मुसक्किनात एंड मुखद्दिरात क्यों दी जाती हैं? क्योंकि दर्द को कम करना है और सूजन को कम करना है। तो डाइट की जब बात आती है तो रेस्ट्रिक्टेड डाइट, यानी सब कुछ नहीं खाने देना है, ख़ासतौर से जो तली हुई चीज़ें हैं, ज़्यादा मसालेदार आइटम्स हैं, उनको अवॉइड करना है। और कुछ दालें होती हैं जैसे कि मसूर की दाल है, ब्रिंजल और करम कल्ला टाइप की सब्जियां हैं, ये सब अवॉइड करनी है। इस तरह से जो मीट के बारे में, गोश्त के बारे में भी है कि काउस मीट और इसके कंसनट्रेटेड डिशेस जो हैं, दिस शुड बी अवॉइडेड। किस तरह की ग़िज़ा लेनी चाहिए? जयदुल कैमूज, यानी जो कि जल्दी डाइजेस्ट हो जाएं, हल्की फुल्की और लाइट, जिनकी कैलोरीज कम होती हैं इनफैक्ट, है ना, कि शोरबा बनाया हमने 2 लोगों के लिए, उसमें पानी इतना डाल दिया कि 4 लोग खा जाएं, है ना, तो डाइल्यूट कर दिया हमने उसको, यानी कि हम कम खाएंगे, कम अमाउंट में जाएगा तो डिजीज़ के होने के चांसेस भी कम है। इसी तरह से चिकन को क्योंकि हल्का आइटम समझा जाता है, उसके क्या कहना चाहिए कि जल्दी हजम होता है इन कंपैरिजन टू द मटन एंड बीफ, तो इसको ज़्यादा तरजीह दें, क्योंकि कुछ लोग छोड़ ही नहीं सकते नॉन वेज खाना, तो वो खाएंगे, तो इस तरह की चीज़ें खाएं तो कम नुकसान होगा। सॉफ्ट आइटम्स एंड इस तरह के बर्ड्स, लैम्स, चपाती खाएं बजाय पराठे खाने के, पूरियां खाने के। वी शुड ऑलवेज प्रेफर। ये तो मैं समझती हूँ कि ये वो चीज़ें हैं जो एक एज के बाद सबको अडॉप्ट कर लेनी चाहिए। और वो एज क्या है? मैक्सिमम 40 ईयर्स। 40 ईयर्स के बाद वैसे खुद ही जो है खाना पीना कम होने लगता है, लेकिन फिर भी शौकीन लोग तब भी 60, 70, 80 साल तक भी खाते हैं। तो अगर इसी स्टेज पे ये चीज़ें कम कर दी जाएंगी तो जो वो वाली एज आएगी, कैंसर प्रोन होता है जब इंसान, तो उसको ये कैंसर्स ही डेवलप नहीं होंगे, है ना। एक्सरसाइज कर रहा है इंसान, नॉर्मली डाइट प्रॉपर ले रहा है, और उसके अंदर कोई मेजर उस तरह की बीमारी की उसके अंदर टेंडेंसी नहीं है, तो ऐसा नहीं है कि हर इंसान को कैंसर होगा। तो मेन क्या चीज़ है कि डाइट पे हमें बहुत ध्यान देना पड़ता है। तो ये कुछ इसमें सब्जियां दी हैं। बथुआ देखा है आपने, ठंडी सब्जी मानी जाती है, पालक की तरह होते हैं, उसके एजेस जो होते हैं इस तरह से जिगजैग होते हैं, और ये सर्दियों में बहुत ज़्यादा खाई जाती हैं सारी सब्जियां, खासतौर से नॉर्थ इंडिया में। पालक आप सब जानते हैं, चुकंदर, बीटरूट, अंगूर, इंजीर, बादाम एक्सेट्रा। The foods which favor food factors which prevent cervical cancer, यानी कि फ्रूट्स भी हमारे लिए बहुत अच्छा रोल प्ले करते हैं। पर यह है कि ये नहीं कि हफ्ते में एक बार एक फल खा लिया, ऐसा नहीं होता है। जैसे कि हम प्रेगनेंसी में बताते हैं ना फीमेल्स को कि दिन में कम से कम 1 या 2 फल ज़रूर खाइए, क्योंकि 3 वक्त के खाने से ऐसा नहीं होता कि उसको भूख नहीं लगेगी, बीच बीच में भी भूख लगती है बिकॉज ऑफ ग्रोइंग फीटस। तो हम वहाँ क्या बताते हैं कि बीच में आप फल खा सकती हैं, बिस्किट खा सकती हैं, कोई सूप ले सकती हैं। 3 के बजाय 5 खाने अगर वो खाने लगेंगी तो दूसरी प्रॉब्लम्स डेवलप हो जाएंगी। तो इसी तरह से यहाँ पर भी है, मतलब ये तो एक नॉर्मल फिनोमेना है कि फ्रूट्स हमें बिटवीन द मील्स लेना है। अगर आप ले रहे हैं नॉर्मली और बहुत लंबे अरसे से ले रहे हैं तो हो सकता है ये भी एक प्रिवेंशन का फैक्टर है। जो लोग बिल्कुल फल नहीं खाते, आप देखेंगे उनको कॉन्स्टिपेशन हो रहा है, तो फलां हो गया, ये हो गया, तो क्यों? क्योंकि वो फाइबर वाली चीज़ें नहीं खा रहे, वो फ्रूट्स नहीं खा रहे, तो जाहिर सी बात है बॉडी में उस चीज़ की कमी हो रही है और वो कहीं ना कहीं फिर उससे डिजीज़ पैदा हो रही है। तो विटामिन सी हो गया, तो इसमें क्या क्या कौन से फल आ जाते हैं? पपाया, किवी, पेपर, ऑरेंज, ब्रोसली, ब्रुसेल्स, ग्रेप्स, स्प्राउट्स, ऑल दीज थिंग्स। सेलेनियम किस चीज़ में मिलता है? ब्राज़ील नट्स, फिश, बार्ले, श्रम्प। विटामिन ई, सनफ्लावर सीड्स, आलमंड, स्पिनच, टर्निप, पपाया, मस्टर्ड। कैरोटीनॉइड्स, कैरेट्स में, टमाटोज में, स्वीट पोटैटो जिसको शिकरकंदी भी कहते हैं, पम्पकिन। एसेंशियल फैटी एसिड्स, ऑल ऑफ यू नो, फिश ऑयल में होता है, फ्लैक्सीड ऑयल में। फ्लैक्सीड ऑयल का तो बहुत ज़्यादा अच्छा रोल बताया गया और आजकल लोगों ने इसको लेना बहुत ज़्यादा रेगुलरली लेना शुरू कर दिया है। इसका रोल रिडक्शन ऑफ वेट के अंदर भी बहुत अच्छा बताया जाता है, वेट रिडक्शन के लिए। तो ये चीज़ें रेगुलरली अगर खाएंगे तब तो कोई उम्मीद है कि इस तरह की अमराज से बचा जा सकता है, लेकिन एक बार मर्ज डेवलप हो जाए और तब आपने लेना शुरू किया तो फिर कोई बहुत ज़्यादा अच्छा इफेक्ट से कोई ख़ास फ़ायदा नहीं होगा। फोलेट लाइक लेंटिल्स, स्पिनच, बीन्स एंड एस्परगस। अब इसके लिए कुछ थेरापीज हैं जो कि आजकल यूज़ में हैं, बताया जा रहा है और लेते भी हैं पेशेंट्स। जिस तरह के जो शांडाफ्तिनीन विच इज़ यूज्ड एज परगेटिव फॉर द ब्लैक बाइल। देन डिकॉक्शन ऑफ उन्नाब एंड सपिस्ता विच रिलीव्स द पेन। मैक्से फुलूस, ख्याल, शंबर, रोगन बादाम, शीरी एंड जाओ शीर। तो ये सब ओरल फॉर्मुलेशंस हैं जो कि बहुत अर्ली स्टेज से देने से ही इसका कुछ इफेक्ट आपको इसका रिजल्ट मिलेगा। क्या हुआ? देन लोकली यू कैन गिव टैम्पून डिप इन द मरहम दाखिलून। मरहम दाखिलून इज अ कंपाउंड formulation which is, देखना है, you will be provided PPTs। मरहम में दाखिलून पे तो काफ़ी इंस्टीट्यूट्स में रिसर्च भी हो चुकी है ना, पीजी स्कॉलर्स ने बहुत काम किया है एंड इट इज़ वेरी इफेक्टिव। तो वो फॉर्मुलेशन लोकली आप टैम्पून में डिप करके इसको होल नाइट के लिए पेशेंट को लगाएं 7 days to 14 days इसका थेरापी होती है। देन मुर्दार संग लेड ऑक्साइड, रोगन जैतून। जैतून तो आप लोगों को मालूम है बहुत अच्छा ऑयल है और बहुत जल्दी बॉडी एब्जॉर्ब कर लेती है। इसकी जो क्वालिटी होती है वो ये होती है कि बॉडी में बहुत जल्दी इसका एब्जॉर्प्शन होता है और पेन किलर भी इसका इफेक्ट है। और दूसरा इसका जो है दूसरे अमराज में भी इसका इस्तेमाल किया जाता है। तुख्म कता, तुख्म कनौचा, तुख्म हुलबा, तुख्म ख़त्मी, इस्पगोल। इस्पगोल को तो एज अ बेस या एज अ व्हीकल यूज़ किया जाता है। सारी दवाओं का डिकॉक्शन बना के आप इसमें इसको इस्पगोल के एक्सट्रैक्ट में इसको डिप कर दें एंड यू कैन यूज़ एज अ टैम्पून और फॉर लोकल एप्लीकेशन। नाउ द डिकॉक्शन फॉर्म यू कैन गिव बर्गर, करनब, ब्रासिका ओलिकेशिया, बनफशा, तुख्म कता सबने देखे हुए हैं। हुलबा, मेथी कैसी होती है, ये सब, बाबूना, बरगे ख़त्मी, इन सबको बॉईल करें और इसका डिकॉक्शन बना के पेशेंट को मॉर्निंग इवनिंग दें तो जो स्वेलिंग है उसमें उसको आराम हो जाएगा। ये सब अर्ली स्टेजेस की ही ट्रीटमेंट है। जिमात के लिए residue left in the utensils before boiling, after boiling water taken and grinded, mix with oil, beeswax to prepare ointment and apply externally over the uterus. तो ये external application के लिए है abdominal. Then tamara यूनिन, egg yolk, रोगन बनफशा, खतनी और दे जॉ, बाले वाटर भी बहुत हल्की उस क्या कहना चाहिए रेसिपी थेरापी है। जो जैसे कि हमने इसमें कहा कि जूद हजम चीज़ें इस्तेमाल करनी चाहिए तो ये लोकली भी इफेक्टिव है और इंटरनली भी इफेक्टिव है। लुआब अलसी एंड लुआब मेथी, स्वेलिंग को कम करने के लिए ये सारी चीज़ें आप इस्तेमाल कर सकते हैं। देन हुक्मा और सपोजिटरी, उसारे, लयुतीस, गिले अरमनी, सफ़ेदा, आबे बारतंग। This is all for if the patient is having bleeding problems. रेजिमेनल थेरेपी, ये टी एक्स्ट्रा लग जाता है इसमें। वेन सेक्शन, तो अभी इसका शुरू में भी जिक्र आया था कि बासेल्यून का वेन सेक्शन करने से इसका जो फासिद सौदा है उसका एक्सट्रैक्शन हो जाता है एंड द स्वेलिंग इज रिलीव्ड. It removes the excess of humors in the same proportion as it is present in blood vessels. It is usually carried out when there is excess of blood in the body and patient is either exposed to the risk of developing a disease or has actually developed. In both the conditions, the aim is to remove either the excess or abnormal humor or both. Vein section of basilic vein is indicated in Rahim, PID, and saphenous vein is in Ehtibas thumbs, that is amenorrhea, to induce the menstruation as it diverts the flow of blood from upper to the lower organs. इस फैन को ऑन करा दीजिए प्लीज, तो कुछ चल नहीं रहा है, हो जाएगा ऑन? हाँ क्या हुआ? Now there are some drugs very specifically given for such type of swelling, some such type of pathological problems. For example, मुरमकी, इसके chemical constituents हैं volatile oil, resin, gum, alkaloids. तो ये tannins, flavonoids, ये सब helpful होते हैं swelling को कम करने के लिए. bleeding problem है तो उसे check करने के लिए. What are the pharmacological actions? Antiseptic, antifungal, antibacterial, cytotoxic, analgesic, antiviral, anti-inflammatory. मेन जो है वो anti-inflammatory, bacteriostatic, astringent, carminative, leukocytic, deodorant, antispasmodic. So it can be given. नोम सबको मालूम है, कसरत तम्स में भी दिया जाता है और उससे तम्स में भी दिया जाता है, यानी कि पेन और स्वेलिंग में बहुत अच्छा इफेक्ट आता है. ये सब इसके इंग्रेडिएंट्स हैं. एक्शन क्या है? एंटी फंगल, एंटी अल्सर, एंटीऑक्सीडेंट, एंटी इंफ्लेमेटरी, एंटी माइक्रोबियल एंड एंटी स्ट्रेस. रोगन गुल सबको मालूम है, रोगन गुल बहुत ख़ास मुरक्कबात में इसका यूज़ होता है। तो यहाँ पर भी इसका जो यूज़ है वो एंटी बैक्टीरियल, एंटी फंगल, एंटी इन्फेक्टिव, एंटी इन्फ्लामेटरी है, वूंड हीलिंग, एनाल्जेसिक, हिप्नोटिक, एंटी डिप्रेसेंट, एंटी एंग्जाइटी, एंटी स्पाज्मोडिक, एस्ट्रिंजेंट, डिसइंफेक्टेंट एंड हाइपोटेंसिव। नाउ सदाबहार, ये तो सीधे सीधे एंटी कैंसरस, इसकी स्टडीज़ हुई हैं तभी इसको यहाँ पर लेबल किया गया है। टेस्टिकुलर कार्सिनोमा, ब्रेस्ट कार्सिनोमा, इन सब में इनका एक्शन देखा जा चुका है। सर्वाइकल कार्सिनोमा, कैपोसिस सार्कोमा, ब्लैडर कार्सिनोमा, माउथ एंड नेक कार्सिनोमा। वेनेसिव गोल, दिस इज एंटी म्यूटाजेनिक, एंटी इन्फ्लामेटरी, एंटीऑक्सीडेंट, साइटोटॉक्सिक, लैक्सेटिव एंड हेमेटोपोइटिक। अमलतास, तो पोस्ट अमलतास के बारे में तो सभी को मालूम है, जो कि है एंटी कैंसरस, एंटी पायरेटिक, एंटी ऑक्सीडेंट, एंटी इन्फ्लामेटरी, एंटी डायबिटिक, ऑल्सो एंटी एपिलेप्टिक, हाइपोलिपिडिक और एंटी माइक्रोबियल इफेक्ट रखता है। अफ्तीमून, साइटोटॉक्सिक एंड एंटी इन्फ्लामेटरी। आंवला, तो आंवला में तो विटामिन सी तो होता ही है, उसके अलावा इट हैज़ एंटी मेटास्टेटिक एंड एंटीऑक्सीडेंट प्रॉपर्टीज़। तो यहाँ पर क्योंकि ब्लीडिंग का भी बहुत ज़्यादा प्रॉब्लम होती है तो पेशेंट को बहुत ज़्यादा हेल्पफुल होता है आंवला के प्रिपरेशंस। तो इस तरह से हमारे पास ऑलरेडी बहुत सारे प्रोडक्ट्स और मौजूद हैं। अभी फर्दर और ज़रूरत है स्टडीज़ होने की, और जिस तरह से मॉडर्न वाले डिफरेंट स्टेजेस के बारे में डिफरेंट थेरापीज़ बताते हैं, इवन डिफरेंट इन्वेस्टिगेशंस बताते हैं, स्टेज वाइज मैनेजमेंट होता है, तो हमारे यहाँ भी उस तरह की स्टडीज़ होने की और ज़रूरत है। लेकिन हाँ, अभी तक जितना भी काम हुआ है, जो भी दवाएं हैं वो ज़रूर इफ़ेक्टिव देखी जाती हैं, और उससे एटलीस्ट इतना तो गारंटी के साथ कहा जा सकता है कि स्प्रेड से होने से रोकता है। हमारी ड्रग से इतना इफेक्ट तो 100% मिलता है कि डिजीज़ बहुत बुरी तरह नहीं फैलेगी, और इन द मीनवाइल आप पेशेंट को दूसरी रेजिमेंट्स ऑफर कर सकते हैं, है ना। ऐसा नहीं है कि भाई पेशेंट आई और बिल्कुल डेथ बेड पे चली जाएगी। नो, यू कैन हैव सम कंट्रोल ऑन द स्प्रेड ऑफ द डिजीज़। उसकी जो इन्वेजिवनेस है, उसकी जो क्रोनिसिटी है, उसको आप कम कर सकते हैं, पेशेंट के पेन को कम कर सकते हैं, प्रोग्रेस ऑफ द डिजीज़ को आप हिंडर कर सकते हैं। सो दिस इज़ मोर देन इनफ। हर्ब्स जो है वो वैसे ही नेचुरल प्रोडक्ट है, तो उसके ज़रिए अगर आपको इतनी हेल्प मिल रही है विदाउट एनी साइड इफेक्ट्स, तो इट इज़ वल्नरेबल, इट इज़ वेरी अप्रिशिएबल। Thank you.
It's like we have to follow the whatever protocols are there. So there are protocols, ma'am, like screen and treat, and then screen, triage and treat. So can we do like this? Like if we are founding the patient at CIN1 stage, then we can anyhow she will be going in the triage, going for the triage. So we can just give our medicine to see like whether it is affecting in like. We can use our medicine in the triage period. Yeah, during the triage period, we can give our medicine. Like, can we do the research studies on this? Because ma'am, actually we lack this thing only, like research thing we lack, like in the Unani system of medicine, like
उसका मैं एक तरीका बताऊँ, उसका एक तरीका बस यही है कि आपने मान लीजिए 50 पेशेंट्स पे स्टडी करनी है, तो आप लीजिए 50 पेशेंट्स और उसमें ज़्यादातर पेशेंट को लीजिए जो आप कह रहे हैं अगर आपको लगता है मिड ऑफ द मीटिंग पेशेंट आप डिटेरेट हो रही है, इसको हमारी थेरेपी से बहुत ज़्यादा फायदा मिला, तो ये रेफर टू द अदर, तो ये स्टडी में कंसिडर हो जाता है कि भाई आप जो है पैरेलल उसको उसकी जान पर नहीं बनेगी, वो पेशेंट बच जाएगा। हमारा काम ये तो नहीं है ना कि हम सिर्फ अपनी स्टडी करें, मेरी स्टडी में नुकसान होता है, दिस इज़ वेरी अनएथिकल। आपको मालूम है मैं अपनी स्टडी की बात बताई बता रही है, जब मैं दिल्ली गई यहाँ सेंटी करके, तो वहाँ पर मैंने एक इंस्टीट्यूट है NIC, नेशनल इंस्टीट्यूट ऑफ कंप्यूटर्स, तो उसमें मैंने डाला ये अपना टॉपिक, तो वहाँ पर ये देखने के लिए कि इस तरह की कितनी स्टडीज हुई हैं, किस किस ने इस तरह के टॉपिक पे, देयर वाज जीरो स्टडी।
Yes, ma'am.
क्योंकि एथिकल मैटर्स की वजह से लोग लेते ही नहीं ऐसे टॉपिक।
No, ma'am. Actually, CIN when they are like they left the patient for trash, na, ma'am. Like
She was treating CN1 cases also, and she was advising the PGs to take as study case, but nobody dared to take. So that is the reason. But yet is they have to keep in mind. For example, CN1 cases. now ऐसा है कि हम ट्रीटमेंट कुछ दे रहे हैं एक केस के also. अब 6 महीने बाद हम देखेंगे वो पेशेंट का, उनका भी बड़ी संख्या, so that will bother us. So rather than that, directly take. Maybe you should not go with actual. Maybe you should not have that step. But you little out. वो एकदम मॉडल अवॉइड करके सी स्कूल स्प्रेड होने छोड़ के then परेशान हो गए सब हो गया, तो that is not fair. Like holistic kind. Yeah, that's what I'm telling you. Go with actual. See, even we had a case, endometrial cancer का case था हमारे पास, निस्वन से patient, दो सर्जरी के लिए ले जाके वापस ला लिए, फिर she is not fit for the surgery. तो tablet लेते हैं करने के वापस आ गए. She came to us. हमने यहाँ पे दवाई बना के दी. बस बड़ी को डॉक्टर से और कुछ नहीं था. वाले क्या चले गए वापस, पहले लोग के उस समय. तो मालूम नहीं मानो हम जो फॉलोअप में देख रहे थे, ये देख रहे थे क्योंकि सर्जरी के लिए अवॉइड कर दिए. This will give. And she improved like anything. Then what we thought, things spread तो नहीं बात देखेंगे. Then we examined. हम imagine नहीं कर सके कि she was having this.
Detecting the cervical cancer with pap smear cytology. Now, what is pap smear test? All of you know. It is also known as pap test. This is a medical procedure in which a sample of cells from a woman's cervix, the end of the uterus and that extends into the vagina, is collected and spread, that is smeared on the microscope slide. The cells are examined under a microscope in order to look for the pre-malignant cells or malignant changes. Now, when to do a pap smear? When to do का मतलब है कि एज के हिसाब से हमें कौन सी एज में करवाना शुरू कर देना चाहिए, पेशेंट को एडवाइस करना चाहिए. All women should have initial pap smear test no later than 21 years old who are sexually active. Then 3 years after the onset of sexual intercourse. Then after the initial test have annually or biannually. Then after the age 30 because it's screened for 2 to 3 years unless has high factor developing cervical cancer. When should it be done? According the cycle, when should be plan it? After the menses, preferably in the mid-cycle. Then, can you tell me why in the mid-cycle? Anybody? Yes. सैंपल अच्छा मिलेगा हमको, फ्लूइड्स के कलेक्शन बहुत ज़्यादा होता है, बहुत ज़्यादा म्यूकस डिस्चार्ज होता है, so we can have a good slide. When there is no sign of inflammation or infection, it is also necessary that we should always ask patient. अगर मान लीजिए सर्विसाइटिस भी है पेशेंट को, आपने पैप स्मेयर ले लिया, अब पैप स्मेयर में इन्फ्लेमेटरी चेंजेस तो दिखा देगा वो, बट इट विल हो सकता है दैट इज ओवरलैपिंग द कैंसरस चेंजेस. तो मेन पर्पस हमारा क्या है कि उसका बिल्कुल रॉ सर्विक्स होना चाहिए, कि यानी कि रॉ का मतलब है कि नॉर्मल सर्विक्स होना चाहिए जिसमें कोई डिजीज ना हो. जब नॉर्मल होगा सर्विक्स, अदरवाइज कि उसको कोई इन्फेक्शन नहीं है, तब फिर जो सेल्स के अंदर चेंजेस आ रहे हैं वो आप ज़्यादा क्लियरली देख पाएंगे. एंड देयर शुड बी नो प्रायर विजाइनल douching और contraceptive cream application because these are hinder in the in the visibility of the cells. Then no sexual intercourse less than before 12 hours prior to the pap smear is taken. Then pregnancy is not a contraindication for the pap smear. Pap smear आप कर सकते हैं in the pregnancy also if the patient has developed some such symptoms. When to stop routine screening? At the age 70, मैडम ने मॉर्निंग में भी डॉक्टर साहब ने बताया था. At the age 70 and adequate recent screening. 3 consecutive negative pap smears अगर आपने हर 6 महीने बाद या हर 1 साल बाद कराया उसका और हर बार 3 बार उसका नेगेटिव आ गया, it means that no need of further screening. No abnormal pap smear in the last 10 years. वही मतलब है कि पिछले 10 साल में उसने 2-3 बार पैप स्मीयर कराया या 5-6 बार कराया तो उसमें से किसी की भी कोई फाइंडिंग नहीं आई एबनॉर्मल, तो उसको आप कह सकते हैं नो नीड ऑफ. देन हिस्टेरेक्टमी फॉर बिनाइन लीजन्स. प्रिपरेशंस बिफोर टेकिंग पैप स्मीयर. पैप स्मीयर करने से पहले हमें मरीज को क्या क्या बताना है. द पेशेंट मस्ट बी एडवाइज टू मेक एन अपॉइंटमेंट अदर दैन ड्यूरिंग मेंस्ट्रुएशन, यानी कि उस टाइम पर उसे आप कॉल करें जब उस मेंस्ट्रुअल फेज में नहीं है. बिफोर अपॉइंटमेंट अवॉइड इंटरकोर्स फॉर 2 days, रिफ्रेन फ्रॉम डूशिंग, सेम है, सीज द यूज ऑफ वेजाइनल मेडिकेशन फॉर एटलीस्ट 48 hours बिफोर. क्या क्या चीज़ें हम यूज़ करते हैं फॉर टेकिंग द पैप स्मीयर. These are slides. This is the bottle for collection of the slides and jumbo swab. Broom is there, spatulas हैं and cyto brush. What you have to do pre-procedure, inform the patient what are you going to do. कि patient एकदम shock में ना चली जाए, what are you doing, and explain the procedure to the patient that we will do this and this. Advise the patient to void, to empty a bladder and provide privacy. Assist the patient to get into a lithotomy position on the examination table and drape the patient, permit minimal exposure. Procedure क्या होता है इसमें? Undress completely or only from the waist down. Lie down on the back and examination table with knees flexed, heels rest and supports called stirrups. Insert speculum into the vagina. Speculum holds the walls of the vagina so that the cervix can be seen easily. Take the samples from the cervix using a soft brush and flat scraping device called spatula. Now, these are the categories of the diagnosis. कि हमने जब सैंपल ले लिया, स्मेल लिया, तो क्या क्या हो सकता, क्या क्या मिल सकता है. NILM, what is this? What is the full form? Negative epithelial lesions and malignancy. ठीक है. And you can get a normal smear, you can get inflammatory smear, you can get non-specific Gardnerella, Trichomonas, and all these HSIL, carcinoma, ADC, and inadequate smears also. So this is the position in which the patient is lying down, and you can see that the cuscous speculum has been inserted, and the brush is being used to scrape the cervix. ये enlarge करके दिखाया है ना, ऊपर cervix लिखा है. इस तरह से 360 डिग्री पर इसको रोटेट करना है, so that you get the cells of the cervix, the squamo-columnar junction. Cells you scrape off and then you spread it on the slide. So this is called the pap test. So this is to call a video. How do we? ये चलेगा इसके अंदर? Can anybody play? 2 बार करने से शायद जाए. इसको प्ले कर दो बेटा, ये 5 minutes का वीडियो है. यहाँ से आ तो रहा है तो कुछ अभी इधर.
Hello and welcome to the channel of Practice in Gynecology. In this video, I will explain about the technique of a pap smear and the liquid-based cytology for the cervical screening. So the things that we will require for a pap smear or liquid-based cytology: pair of gloves, some clean glass slides. This is known as the Ayush spatula, the cyto brush, we have the cuscous bilateral speculum, and for the liquid-based cytology, we have this one known as the cytobroom and a liquid-based cytology vial. So beginning with the procedure. So first you need to perform an adequate hand hygiene, and after that don an extra well pair of gloves as per your size, and then finally you will introduce the custos speculum. See, custos speculum is for the retraction of anterior and the posterior vaginal wall, right? But we don't introduce it as such. It's very dramatic operation. So basically you take it to 90 degree like that, and then you insert it right through, and then finally you take it and open the, so now the anterior and the posterior vaginal walls have got retracted, and you can see that the vaginal walls appear pink, and the cervix is also seen in the center, and here I can see in the center of the cervix is my os. So this would be the area of my interest, and where I will take the pap smear, and I can adjust this to right over here so that it does not get closed. There you see is my os, and now if I have to take the pap smear, I will require a Ayush spatula. So now I am going to introduce my Ayush spatula. So here you can see the Ayush spatula, and the longer end of this Ayush spatula is going to go inside the os, and the smaller end is going to remain outside the cervix. And we are going to make some rotations. To make it more clear, I am going to explain it on my hand. So imagine my hand is a cervix, and you can see is a slit shaped external os. So now I am going to take the pap smear with the Ayush spatula. So I am introducing the Ayush spatula through the vagina till the cervix. Now it has a long end and a short end, as you can see. The long end is going to go into the endocervical area, and the short end is going to stay over the cervix, rest of the cervix that is outside. And we are going to make some rotations like this, right? We will make 2 to 3 rotations, and finally and also in the same direction. And after making those rotations, you get adequate amount of cells, and you spread it over the glass slides 2/3 area. Immediately you have to spread these. Next comes up is my cyto brush. So this cyto brush is going to go inside this, going through the external os into the endocervical canal, and you can see, still I can see some of my bristles outside this, outside the cervical canal. That is absolutely normal. And next is I am going to turn it just half of the circle, and that half of the circle is enough to take the endocervical sample, and I am going to spread it over the rest part of the slide, where over the 1/3 area, right? And then you have to immediately fix this slide with a fixative solution, which is of 95% alcohol to ether 1:1 ratio. And after that fixation, we go for the pap staining, right? So this was all about the pap smear. Now there is a new technology, that is the liquid based cytology, for which I will require is a cyto broom or a combi brush. This is a cyto broom. See, it has bristles over it, and it also has a tip inside it, in longer end in the middle, you can see, which goes right inside the endocervical canal. So again I am going to introduce it right through the vagina into the cervix, and then I am going to rotate this over the cervix, and you can see in the same direction I am going to go for 4 to 5 times, and after that I have taken enough of the cells, and I am going to transfer this part of the cytobroom, right? It gets detached, and the cytobroom is then put inside this shore path vial like this, and then sent for the liquid based cytology, to the authorities. See, the liquid-based cytology has a few advantages from the platform for pap smear. That when you make the pap smear on a glass line, it has some drying side effects. Whereas in case of a short part, it's a liquid-based cytology and there are no drying effects. And the number of cells that we transport in this are more in comparison to the pap smear. For example, you can say that almost 80 to 90% of cells that we take gets transferred in this, whereas in case of pap smear it would be only 10 to 20%. And the next we have is in case of a presence of blood or mucous discharge, those cells they get separated from the endocervical cells in this method, and also you can go for a HPV DNA testing in this blood. So it has a few advantages from the pap smear. So some prerequisites that you need to follow before taking this process. That is, the patient should be in a post-menstrual phase, or you can say any time away from the menstruation, and not in the menstruation you should take the pap smear. But if there is a slight presence of blood cells, or you can say there is a slight bleeding, you will go for a LBC method for the cytology testing, because that separates your RBCs from the endocervical cells. The next we have is the patient should have no coitus, no douching done, no use of tampons for at least 48 hours prior to the cytology sampling. And also, if there is any presence of a vaginitis or cervicitis, you need to first treat that part and then take a pap smear. By inserting your Cusco speculum, make sure that you do not use any lubricants or any antiseptics before inserting, because that will hamper the cytology. So thanks for watching the video, and if you like the video, please do like, subscribe and share the channel. Love of Starters and Gynecology. Hello and welcome to the channel.
Thank you very much.
And analgesia, emerging trend and challenges.
Oh my God, Napcha. Good evening all. Thanks for the introduction. First of all, I would like to thank the organizing committee for giving me this opportunity to be here on this occasion. First of all, I would like to thank the organizing committee for giving me the opportunity to be here on this occasion. You all know that normally I get this post-lunch session, so I'm little worried because after the lunch everyone feels like a sleepy mood. So I last lecture also I told them it is easy to put someone to sleep and difficult to wake up. So I'll try to keep you all awake with a few points. Okay. Why this topic? So you all can ask me why? Because labor is normal process. Right from human being to animals, everyone gives birth. Birthing is the natural phenomenon, and you all know that. How the labor starts? Any idea? When can you say mother has gone into labor? No? Pain. Every time she comes to your clinic smiling and suddenly she comes with then you think that probably she is gone into labor. So pain is the start of the labor, but we are trying to block that here, correct? So why we should block the pain? What is the importance of blocking the pain? Let's see, okay? Now, we'll discuss the topic under a few headings: history, definition, physiology, ideal labor analgesia, paracervical block, pudendal. You will come to know what all the techniques, recent advances, and with a summary. And last one, case discussion. I would like to see how many people are awake at the end of the topic. Let's see by answering these case discussions, okay? Now, if you go back to the history, anything goes with the history. If you see, the person who does first will not get the name. Okay, so whoever does big thing, no, they will get the name. Even though in 1847, James Young Simpson, who discovered ether, then chloroform, used it for analgesia, was the first to start painless labor. But he didn't do it on a VIP, that's why he didn't get name. 1853, John Snow, who administered chloroform for Queen Victoria for the birth of the 8th child. His name is Prince Leopold. So naturally the princess going for labor analgesia, it will be a big news. Like Narendra Modi does something, it will be a big news. So finally 1853, John Snow got recognition for the inhalation anesthetic. Now let's see what is labor basically. Labor is nothing but the frequent contraction to push the baby out. So the process of contraction followed by simultaneously the mouth of the uterus should open. What is there in the mouth? Cervix. So we know that continuous contraction, stretching of the lower segment and dilatation of the cervix. So three processes involved in labor: contraction of the uterus, stretching of the lower segment and opening of the cervix, that is thinning and dilatation of the cervix. Now why this has to be painful? It's a most, believe me, it is going to be a most intense pain. I'll tell you how severe is the pain. If you closely watch in this slide, there is something called McGill pain index scale. Here we grade the pain right from 0 to 50. 0 to 50, if you slowly see, if you had a fall or you had a sprain, the pain will be 10. Ankle sprain, knee sprain, hand sprain, it's just a 10 pain score. And if somebody cuts the digit, amputation, the pain will be 40 or 50 without anesthesia, I mean. Okay, the pain is so severe when you do a amputation, it is around 40 to 50. Now if you slowly close to see on the right side of the scale, I have put childbirth is equivalent to cutting the digit, that is amputation, and also causalgia. Causalgia, sorry, this one. So right side of the scale, it is written childbirth. So childbirth pain is so intense, it is equivalent to amputating the digit or causalgia. Causalgia is nothing but whenever any part of the body, lack of blood flow becomes avascular. So, yeah, it's going but no. Okay, so in this childbirth there are two ways. If you can train the mother, the scale comes down to 30. The pain scale comes down to 30. If you don't train untrained mother, the pain scale goes to 40. So by training the mother, just by training you can reduce the pain felt by the mother. Okay. Now after understanding the labor, let's see the stages of the labor. Now once you understand the physiology of the labor, then only we can tackle the problem. Now stages of labor, labor is divided into 3 stages: from the onset of contraction to the dilatation, and from dilatation to the expulsion of the fetus, and finally placenta. This is very familiar to all of you. What I want to point out here is it goes in a time fashion. For a primate is every 1 hour 1 centimeter gets dilated. So if you want 10 centimeters, you have to wait for 10 to 12 hours. In a primate, exactly half of it in a multi. Because once you know the duration of the labor, then only you can control the pain. If you control the pain and the time goes up, obviously the obstetrician will scold anesthetist because unnecessary painkillers de diya to zyada time ज़्यादा बढ़ा दिया. So prolonged labor, all that. So to know prolonged labor, you must know what is the normal duration of the labor. So first stage is 12 hours for primary, 6 hours for multi. Second stage normally dilatation to expulsion in a primate takes not more than 2 hours, and for multi it goes very fast, 30 minutes. So to say a prolonged labor, somewhere between 2 hours in a primary or more than 30 minutes in a multi, or 3 hours in a primary without analgesia, without painkiller if it crosses 3 hours, or without painkiller if it crosses more than 1 hour, then only we call them prolonged labor. Why you must know prolonged labor? You must know when to convert mother from normal delivery to cesarean. Many times we get the blame. Suppose we had not put an epidural, not blocked the pain, probably mother would have delivered normally. So we must know how much duration it gets prolonged by using painkillers. That we'll know at the end of the topic, okay? And for third stage, obviously, 15 minutes. Why 15 minutes I have mentioned? So we have something called retained placenta. So how much time you can wait for a placenta to stay inside after the baby comes out. So we know that 15 minutes is the normal time. Maybe if it is adherent, maybe if it is hourglass contraction, maybe if it is prolonged stage, probably they may stretch to 30 minutes, not beyond 30 minutes. So then only you go ahead and do manual removal of placenta, right? Now coming to the physiology of labor, now why this labor pain comes, how exactly, we'll see. So we have two stages as I told earlier. First stage is only contraction and stretching. Contraction and dilatation. So what contracts? Uterus contracts. What dilates? Cervix dilates. So both are inside the abdomen. So this is carried by visceral fibers. Visceral fibers are A delta and C fibers. Okay. So whenever we get stomach pain, which is from the viscera, heart pain, which is from the viscera, lungs pain, which is from the viscera once again. So all these pain are dull aching pain because they are carried by C fibers. C fibers are slow conducting fibers and dull pain, okay. So whenever you see mother coming to your OPD with a dull pain, you must probably presume that it is from the uterus and the cervix. Maybe she is in the first stage, okay. That's clear. Now the second stage pain normally comes when the baby is pushing the perineum. Already the dilatation has occurred, contraction is there. Then the head comes to the perineum, perineum gets stretched, the upper vagina gets stretched and there is a tear of the lower vagina or the perineum. So this is from the skin and the mucosa. So skin and mucosa is not the viscera, it is peripheral pain. Okay, so if you closely divide pain now, first stage pain is mostly visceral pain, second stage pain is somatic pain. It is from the skin and the other structures because of the stretching, tearing, okay. So it is also conducted by A delta fibers, but please note the nerve dermatomes. First stage pain goes through the inferior hypogastric plexus to T10 to L1. We have marked the spinal cord. So 10th thoracic to first lumbar is the track where the nerves goes. Then only you will know where to block the nerves. Second stage, the pain impulses go through the sacral plexus into the spinal cord. So that is from S2 to S4, okay. Now why there has to be pain during the labor? Now there are many mechanisms explained. There are basically in the first stage, because of the uterine contraction, myometrium will go for ischemia. There is reduced blood flow to the uterus. That senses and releases pro-inflammatory substances like substance P, bradykinin, histamine and serotonin. All these chemical substances irritates the nerve and causes pain. Now second stage of labor, where there is a stretching and distension, we have something called mechanoreceptors. Anything stretching excessively is painful on the somatic area. So second stage, because of the mechanoreceptors, pain comes. Now why is that physiology of pain is most important? Because once the brain senses the pain, there is something called increased anxiety. Now once the anxiety increases, automatically the sympathetic stimulation which is in the center portion gets stimulated. Any sympathetic system in the body releases adrenaline and stress hormones. So once the adrenaline and stress hormones like cortisol and all released, they have secondary effects on the body. As you already know, when there is adrenaline is stimulated, you will get excited. So heart rate will go up, cardiac output will go up, and person will start breathing fast, hyperventilation, and along with these there is something called acidosis. Because of the excess breathing, carbon dioxide gets washed out. So what is left out is the metabolic substances in the periphery. That also because of the reduced blood flow, the anaerobic pathway takes over and the accumulation of lactic acid, which we call it as a maternal metabolic acidosis. Along with these, you also know that catecholamines adrenaline cause vasoconstriction and reduce the blood flow to the uterus. We already know that the pain is because of the ischemia, reduced blood flow. So this pain further worsens because of the release of adrenaline. Uteroplacental blood flow reduces because of vasoconstriction. So finally, if you see, pain has three basic mechanisms. One is metabolic acidosis, reduced uteroplacental blood flow, and same changes also happens in the baby, that is fetal acidemia and hypoxemia. So you should not only think about what's happening in the mother, you should also think that what are the after effects which is happening inside the baby because of the maternal change. This is basically neurohumoral changes, that means neurohormonal changes. Why all this is happening? Because of the release of oxytocin, estrogen. Okay, progesterone has taken over it. Later on comes the prostaglandins and cytokinins. Okay, these are the chemicals which are causing the effects. Now, I was mentioning the first stage is concerned with T10 to L1 and second stage is S2 to S4. This always you should keep it in your mind. Now if you see, the same dermatomes also supplies the skin. For example, anybody getting pain in the gallbladder, there is a referred pain in the shoulder. So why gallbladder pain has to be referred to the shoulder? So many people start saying, yes, irritation of the diaphragm? No. The nerves which are supplying the gallbladder is C23. The shoulder is supplied by C23. The same nerve supplies both the area. Probably this pain is sensed as a pain on the skin. Similarly, the same referred pain is also felt on the surface of the body. And if you slowly see, the umbilicus is marked as a T10. Okay, so T10 and below that. So T10, T12. So L1 to T10 to L1 is below the umbilicus. So normally you have seen any mother with labor pain, she comes holding her lower abdomen, not the upper abdomen. I've seen anybody holding upper abdomen. They hold lower abdomen because the pain is below the tummy, below the umbilicus, T10 to L1. And some mothers do keep her back like this, indicating that the pain is in the sacrum area, S2, 3, 4. So that's how you know that which dermatome is involved, basically. Now here I have marked it in 3 colors. Mild is pale color, moderate is almost a brick red color, and severe is little darker red. Okay. Now each stage is, we divide once again into early stage and the late stage. Early stage in the sense, first stage is early, first stage is late, second stage early, late second stage, like that. Okay. So early stage, mild pain, lower abdomen, and late first stage, sacrum area is involved because the cervix is going to dilate through the pudendal nerves. Okay. Now as the pain progresses to second stage, the pain gets shifted from lower abdomen, sacrum to the perineal area around the vagina and inner side of the thigh, because the same nerve is supplied there. So the pain will be mild at the vaginal area and slowly it gets spread to the inner thigh, and the pain becomes intense. So mother who was complaining of lower abdominal pain, back pain, suddenly she says, I have pain at the urethral area, then you must probably think that she is progressed fast and dilatation has happened. She has gone into second stage. That is the time you can go ahead and do pervaginal examination. First stage, if you do PV, you will not find anything because the os is closed, only contraction is coming. Once the dilatation occurred, you want to know what stage the head is. So that is the probably when a mother says that I have severe perineal pain, that is the time you have to go, because repeated PV is also not advisable whenever there is rupture membrane, you are going to transmit the infection. Okay, so by understanding the pain pathway, you can roughly assess the stages of the labor. Now if you don't treat pain, what happens? What are the side effects? So by increasing the respiratory rate, you are going to push the mother into hypocarbia, increased oxygen consumption. So imagine a person is asthmatic already with low oxygen, they are delivering the baby asthmatic. Such a mother, you allow to breathe fast, oxygen consumption goes up, carbon dioxide gets washed out. So what? Carbon dioxide is a bad gas, let it go, you will all feel. But hypocarbia causes strong binding of oxygen. Displacing carbon dioxide binds oxygen. So imagine mother has got low carbon dioxide, more oxygen binding, oxygen will not go to the baby, baby will go for hypoxia. So you want oxygen to be delivered fast to the baby, sufficient carbon dioxide should be there in the maternal blood. If mother starts breathing fast, baby will not get the oxygen. That is the reason baby will go for hypoxia and acidemia, which is written in the bottom. That is one thing. Second thing, imagine your parturient mother is a cardiac patient, already she is compromised with the low cardiac output, maximum heart is beating like a, so you can only run to one extent, after that you can't run, your body gets exhausted. So imagine the heart is also similar, by beating fast, 110, 120, such a mother you allow pain to go, then pain will further cause load on the heart and causing pulmonary edema, because there is increased peripheral vascular resistance. So BP will go up, heart rate will go up, cardiac output will go up, and peripheral vascular resistance will go up. Obviously, if your patient is pre-eclampsia, they will throw convulsions if you allow them to go for normal delivery. So whenever high BP is there, it forms your thought to tell an anesthetist to be prepared for labor analgesia to reduce the blood pressure and the load on the heart. The second column on the right side, which I want to make it very familiar, gastric emptying. Whenever we all know that exam is there, tensed up, we don't feel like mother will be forcing have food and go. No, it's not digesting, because the gastric emptying gets delayed when there is adrenaline and cortisol, stress hormones. So similarly, in a pregnant mother, there is delayed gastric emptying, gastric stasis. Not only because of cortisol, you all know the expanding uterus pushes the stomach horizontally and prevents emptying. So you know whatever you give will stay in the stomach. So don't think of giving any painkiller tablets to a pregnant mother, because it will not get emptied, it only stays in the stomach and absorption will be slow and erratic. The more time it stays in the stomach, more drug gets absorbed into the system. And another worst effect is they don't take only tablet, they take water also. So you are going to make mother into full stomach. If she vomits and becomes unconscious during convulsion, the same content can go and cause aspiration. So don't keep the mother, don't give anything orally for painkillers. So the other side, right side, so what happens when there is a sympathetic, if epinephrine, norepinephrine gets released, this causes incoordinate contractions of the uterus. We want coordinated contractions to push the baby out. So when there is incoordinate contractions, the uterus, baby will not come out, rather baby will go for deep transverse arrest, or it is retention, or incoordinate contraction, or failed labor you say. So they are the ones who can go for C-section. Also the placental perfusion, as I was mentioning, uteroplacental blood flow, when it gets reduced, automatically the blood flow to the baby also gets reduced, causing fetal hypoxia. So when you know all these problems, you write exactly opposite. They are the beneficial effects when you block the pain. What? Reduces anxiety by blocking the pain. It reduces fatigue. And it reduces, it prevents incoordinate contraction, dysfunction labor. It also reduces the side effects of the catecholamines by blocking the pain. And you are going to improve the blood flow, because by giving sympathetic blockade, you are allowing the vasodilatation and increasing the blood flow to the uterus. Automatically the pain is less, they breathe less, oxygen consumption also comes down by, if you want to remember, 12 to 16% consumption comes down. And it also prevents hyperventilation, fetal acidosis and hypoxia. Now what should be your ideal labor analgesia? Now whatever the drug you give, it should be safe for mother and baby. So whatever you are giving to the mother should not harm the baby. That should be your first motto. And second thing, it should not interfere in the labor process. What is the labor process? Contraction. So any drug you are giving should not block the contractions. Contractions should go automatically in a spontaneous way, but you are going to block only the pain. This you should remember, because when we are discussing the techniques, you need to keep this in mind. Third thing, it should be flexible, it should be easy, it should not be complicated, like take to the OT, connect all the monitors. Mother is already scared about her pain, and if you do complicated procedure, I think you will not accept that. So it should be simple and easy, and it should provide consistent pain relief. That is the reason I was telling 10 hours or 12 hours for primary, 6 hours for multi. You have to have patience to treat the mother for 12 hours. Your painkiller or your technique should work for 1 full day. You can't give 2 hours acting medicine and then they'll have given painkiller. Just lie down and deliver. No, it will not happen. You must monitor. And the technique what you're going to use should have a long duration of action with minimal side effects. Now coming to the techniques, what and all you have. Basically for a layman we say non-specific, specific. Non-specific technique is called non-pharmacological methods, where we are not going to use any medicines. Pharmacological, we are going to use medicines. Pharmacological medicines, in what route you are giving. Already I told don't give by mouth. So you can only give by 3 routes. One is by breathing. You don't mind medicine going into the lungs. It is called inhalation technique. Other one you are going to inject. It is called systemic technique. And third technique is called regional. You are going to block the region. You know T10 to L1. So you don't have to block from brain to spinal cord. You are going to block only the few segments. That is called regional technique. Okay. Now let's see one by one. Continuous labor support. Here the last time also I was telling to the PG here, all my PGs, like continuous labor support is one of the best technique where you train the mother in the OPD itself, saying that this is going to be normal, you're going to get pain, you have to little manage and you will deliver fast and you can enjoy the delivery, all that. If I make you unconscious, you will not feel the pain, you will not see your baby, you will be drowsy. When you prepare all that, no mother is prepared to handle the deliveries. Now who has to give continuous support? Who has to give continuous support? So I gave choice last time, should the obstetrician give the support, or should the mother-in-law give the support, or mother give the support, or husband give the support? I think somebody must have read the last line, I think. Not necessary. Yes, husband has to be there, but I always give the example, husband is working in the army, he can't come for the time of delivery, flying all the way from the border. So someone else has to be there, no? So maybe mother or the obstetrician who is very good in terms. That is why I always tell them while doing antenatal checkup, check for the baby's condition. I am not saying no. Check also mother also, because she should feel that, she should feel gynecologist as her mother. Then only she will come openly. So you train her in such a way that I will be there with you during the delivery. Just ऐसे देख के चले गए तो डॉक्टर चले गया घर जाके टीवी देख रहे हैं. It should not happen. You give her confidence that I am going to be there till the end. I will be there. Your pain is like my pain. Yes, always is the headache. The moment any patient comes to labor room, it is your headache only. Forget about her labor pain till she delivers. Okay. So husband is one thing. ठीक है. Second technique. One is continuous labor support. There are enough studies to prove that when husband is there, duration comes down and cesarean section is less. He will be standing next to her telling no, if you don't force, no, खिलेगा नहीं तो cesarean कर देंगे करके. तो cesarean will not. So maximum normal deliveries has happened. There are many studies to prove. Psychoprophylaxis. So the name suggests that psycho, something to do with the brain. Prophylaxis means before. So these are the techniques should be done before the onset of the labor pain. You have to train the mother in such a way, mentally prepare her before the delivery. She is already struggling with the pain and go and sit her and train her. No, you breathe, I am going to tackle your skin. No, she will not hear your words. So train her well before. So for this I would like to tell you one important example. So sometimes what happens, one of my friend had gone for a movie. So normally he has an habit of saying, somebody neighbor asks where you are working, he says I am bank employee. He will not tell I am doctor. Why the moment you say doctor, they will start, मेरा दीदी का मेरा mother-in-law को headache है, किसी को पाँव का दर्द है, किसी को backache है. They will not allow you to see the movie only. So you will just go and sit and tell something. So it so happened that the person who was sitting was not allowing him to see the movie. They were telling, अरे यार कैसा movie आ गया, सिर दर्द आ रहा है, सिर दर्द है. So what he did, anyway leave. He gave one tablet to his hand and told him keep it under the tongue. After you keep it under the tongue, after 5 minutes your headache will come. He was watching movie. Movie went over. Then at the end of the movie he asked, how was your headache has come? Yes, it has come down. Then he asked, then give me that button, my shirt button I gave, saying the time. in the dark room. No, he has kept it is not dissolving, it is under the tongue. So, something psychoprophylaxis, you prepare mentally, you can tackle the pain. Yes, it is there. So, there are two techniques, Lemaire's, Leboire. You must remember these two, this one. Lemaire's technique basically involves the breathing techniques. It is nothing but the conditioned reflex. You are going to distract the brain by giving certain exercise to the mother so that she gets diverted. That is Lemaire's technique. Leboire is a French man, I don't know how to pronounce. Leboire technique is a different technique. I'll explain later, okay. First let's see the Lemaire's technique. Here you are going to train the mother reflexes, so she gets conditioned to that reflex and she will forget her pain. What are the techniques you use here? One is human support. You are going to stand next to her and you are going to tickle the skin and tell her that she will concentrate on the sensations on the skin, and at the same time you should tell her to breathe. Breathing is also an art. She should not breathe when she is at rest and at the pain, she has to hold the breath. Then again apnea. Apnea causes acidosis. So you have to tell that you know pain is coming. That is the time you start increasing the breathing time. Don't hold breath at the time of contractions. So you're going to train her breathing technique. At the same time, you're going to tell her that don't hold so tight. You'll be feeling that the gynecologist hand will be totally squeezed. You tell that relax, relax, don't squeeze like that. Just relax all the muscles. But relaxation helps in two ways. One thing is the head rotation and expulsion happens very freely. If they hold the muscles very tight, the last minute rotation will not happen in occipito-posterior patients. Okay? So relaxation is another technique. The techniques what I mentioned will have a positive effect on the mother. So Lemaire's technique, what are the advantages? There is no effect on the baby, and there is no medicines used. Side effects of the medicines are not there. Mother will easily accept. And this will work right from beginning till the end of the delivery. Ideal labor analgesia, few things has been taken care. But if there is release of inflammatory substances in the body, irritating the nerves, this will not work. This will only diverts the mother, causing a blockage, conditioning. Okay. So you have to use, when it comes to the second stage severe pain, you have to use some technique which is to be effective in the second stage. Now other technique is touch and massage. You start massaging the lower abdomen. She says abdomen pain, start massaging. And there is something called counter sacral pressure. Now whenever the head is pressing on the sacrum, the hypogastric plexus on the sacrum is getting stimulated, so she will have sacral pain. So you give a counter sacral pressure so that the baby head gets pushed front and the pain comes down. So counter sacral pressure, touch and massage to some extent will reduce the pain. Now whatever we have learned other than this, I forgot to tell you, if the mother has already come with urine, then the bladder gets stretched, the pathway is different. If mother has not passed the stools, the rectum is loaded with stools and head is pressing on the rectum, the track is different. मतलब you should not tell that sir ने बता दिया नहीं T10 to L1 था इधर देखते ही कुछ और dermatome stimulate हो रहा है. That means the bladder innervation is different. So when you happen to see that the diversion is some other dermatome, she is no lower abdomen में ही pain आएगा. Doctor ने बता दिया नहीं upper abdomen भी हो सकता है. When bladder is distended, she will have whole abdomen pain. That time you should realize that you have to pass a catheter, empty the bladder so that the pain comes down by doing a small procedure. Or if she comes with loaded rectum, she is there that no gluteal region में pain आ नहीं sacrum ही आता है, gluteal में नहीं आता. नहीं, loaded rectum can be gluteal pain. So you give enema, gets empty, it will be okay, comfortable. So you need to understand that, and whenever there is an abnormal presentation, imagine that the head is not rotated, it's in abnormal position, yes, there is possibility pressing on the iliac veins, there can be possibility of other abnormal pain. So whenever there is abnormal pain, you should think that there must be something abnormal presentation. So this baby cannot go for normal delivery. Usko पकड़ के analgesia कर दे, no, epidural will not work, okay? Therapeutic use of hot and cold. So there is other receptors in the body like temperature, hot and cold receptors. So alternately you stimulate with that hot and cold compress, that also reduces her pain by diverting the mind. Hydrotherapy. Hydrotherapy is something which is followed long back, and now it has become a 5-star fancy way of treating in corporate sector. They started saying that birth underwater. We call it hydrotherapy, they call it birth underwater. They create a tank, make them sit under. It's like everyone feels like enjoying, no, going to resort. What you will enjoy? No swimming pool means no happy. So you have to jump into the swimming pool. So cold gives some kind of comfort. So you allow mother to sit in a tub which is filled with lukewarm or cold water and allow her to deliver in the water itself. So baby comes in the water because baby doesn't have to breathe. It is taking circulation from the umbilical cord. So baby will not aspirate and nothing will happen. The moment you cut the cord, baby should be out of the water. That is most important. The problem is if the water is infected, mother can transmit the infection and cause chorioamnitis. Now this is something different which has done a huge meta-analysis on 2013 patients. They have done study, 15 studies altogether on a woman. Vertical positions, what is this vertical positions? Now when I was a student, I was just thinking why the labor room is full of mothers walking, because normally we see walking in the morning and evening. But here whole day mother will be walking in the labor room from here to there, here to there. I was really wondering, later I realized that by doing this study they have analyzed that if you allow mother to stand in a vertical position during the contraction, because of the gravity, upright position, it reduces the duration of the labor and reduces cesarean suction. Even analgesia sometime. Intradermal sterile water injection. Please note, this is not hydrotherapy. This is something different. Intradermal, through the skin, you are going to inject water that is going to stimulate certain nerves and prevent the pain. Now, afferent nerve fibers usually travel through T10 to L1. So, we know that the posterior iliac spine, which I have mentioned in the diagram, we select 4 points, 0.5 centimeters or 1 centimeter medial and 3 centimeter caudal. We are going to inject 0.05 to 0.1 ml of a sterile water, ice cold, saline. You can inject either saline or water, and we all know that the water is irritant to the nerves. By stimulating the skin, you are going to block the nerves which are carrying afferent impulses. Now what are the advantages? Water has no effect. So this all GPs will do. Anybody goes with pain repeatedly to the clinic, what GPs will do? They will inject water and collect the money and send them, go home, you will be comfortable tomorrow. No fever will come, no backache will come. So injecting water has been done long back. So it's got no effect on the mother, no effect on the baby, and do not come in the way of labor progress. These are all the advantages of water injection. Now there is something which is more advanced. It's called electroanalgesia. Now the latest technique is electroanalgesia, audioanalgesia. Electroanalgesia, we use small electric current to stimulate the nerves. Audioanalgesia, we play music to the mother which causes soothing. The familiar technique is TENS, transcutaneous electrical nerve stimulation, where we place certain electrodes on the dermatomes and stimulate with low voltage current that prevents the afferent impulses and works as a gate control theory. This you must remember, the impulses go and cause presynaptic block at the dorsal horn. We all know that the afferent impulse goes through the dorsal horn of the spinal cord. This causes presynaptic inhibition by the low voltage current placed on the skin. So this is carried by C fibers, and best example is gate control theory. So where to place the electrodes I have shown in the pictures. First stage you are going to place high up, and for the second stage the same electrodes will come little lower down. Now what are the advantages? Easy to use, it doesn't come in the way of delivery, it doesn't affect the fetus condition, and this is basically painless. Intradermal injection is painful, but this is non-invasive. Now we have done with the non-pharmacological, non-specific techniques. How it works, where it works, we don't know. Now let's come back to the specific techniques, pharmacological techniques. The best method is inhalation, which started in long back 1853. Inhalation anesthesia, where you are allowing mother to breathe the gas. Now by that way it gets into the lungs, goes to the brain, and then the same way it comes out by exhalation. Now what is the problem? the whole anesthetic gas goes to the brain, so mother can be drowsy, she can be unconscious, she can aspirate. So to give inhalation analgesia, inhalation technique, mother should be in an empty stomach and you can't allow her to become drowsy. If she becomes drowsy, she will not cooperate you for pushing the baby out. Okay. Now what is the medicine we use here? Entonox is the drug we use. Entonox is nothing but the equivalent mixture of nitrous oxide and oxygen in the ratio of 50-50%. It comes in a preloaded cylinder. So you all might have heard what is nitrous oxide? Yeah, but here mother will never laugh. It's only in the books they say call it as laughing gas. Now nitrous oxide is the best analgesic, but the problem is nitrous oxide is lighter than oxygen, heavier than oxygen. So what happens when there is heavier? In a cylinder, if you keep a nitrous oxide oxygen, nitrous oxide settles down, oxygen goes up. So in a cold temperature like Himalayas, mother starts inhaling, first she will inhale all the oxygen. What comes next is the nitrous oxide. Now what is the problem with nitrous oxide? When you give nitrous oxide alone, it displaces oxygen from the blood and causes hypoxia. So nitrous oxide causes hypoxia in the mother. Same way baby also can develop hypoxia. That is the disadvantage. So this can also cause drowsy, this can cause hypoxia, we can deliver and causes of aspiration. These are all the disadvantages. Advantages, it doesn't come in it doesn't relaxes the uterus, so it doesn't affect the uterine contractions and it has no effect on the neonates in the fetus. So volatile inhalation anesthetics, those are the anesthetic agents we use for anesthesia. So in a low dose it also causes analgesia. So what are the medicines we are using? Desflurane, enflurane and isoflurane, and latest is sevoflurane. Why we don't use desflurane, enflurane, isoflurane? Because they are irritant to the airways. If a mother is an asthmatic patient, the moment she inhales, it is pungent, it is just very irritant. So the moment you keep it on their face, they will not accept. There can be chances of bronchospasm, all that. Sevoflurane, yes, and like Entonox, there is something called Sevanox or Sevox. It is given in the dosage of 0.8%. As long she inhales, she will have analgesia. The moment she stops inhaling, she comes back. So inhalation analgesia, there is a technique. You must allow mother to breathe only at the time of pain. If there is no pain, you have to remove the mask and keep it away. She can't keep the mask all the time and inhale. She will go into deeper plane of anesthesia. So what are the advantages of inhalation agents? Easy to administer with only mask. You don't require any IV cannula, fluids, monitor, all that. And it produces satisfactory analgesia, minimal neonatal depression. But please note, even though I said minimal neonatal depression, the inhalation anesthetic agents cause uterine relaxation. So that is the reason we use all these inhalation agents only for manual removal of placenta. You want to relax the uterus, put the hand inside and take the placenta out. So you know that inhalation analgesia, anesthetic agents causes uterine relaxation. So this is not a good drug because it decreases uterine contractility except nitrous oxide. Nitrous oxide comes in the way of uterine contraction. There is risk of unconsciousness and aspiration will be there. Now coming to the systemic analgesia, I said systemic means we are going to use into the system, we are going to use into the venous system. Now we have only 3 drugs here, opioids, sedatives and ketamine. Opioids are the good old techniques, morphine is nobody using. Next to the morphine is the best wonder drug is pethidine, which is very good drug. It is given in the dose of 25 to 50 milligrams. If you want to remember, 0.5 to 1 milligram per kg. But one important point I want to tell you about the pethidine, see the onset and the duration. Onset starts 5 to 10 minutes after the injection and maximum effect is 2 hours. This crosses the placenta, please remember. So you have to use pethidine if your baby is delivering after 3 hours or before 30 minutes. Because by the time pethidine given, if your patient delivers in the 2 to 3 hours, most of the medicine will be in the baby. So it will go for respiratory depression. So don't use pethidine if your patient is delivering within 2 hours. After the 3 hours, pethidine effect would have over, then let her deliver, no issue. Okay. So the causes, any opioids, you have to write 4 side effects. One is respiratory depression, other one is pruritus, itching, okay, nausea, vomiting, okay. So all these, and aspiration. So all this you can write it for opioid side effects. Now older gynecologists used to use pethidine with phenargan because pethidine causes vomiting, phenargan prevents vomiting. So 50 milligrams of pethidine, 25 milligrams of phenargan, combination IM is going to be the best analgesic agent for labor analgesia. But when you are giving this, first stage of the labor, because we know first stage is 10 hours, 6 hours. So you can give first stage pethidine, not second stage. Second stage is 2 hours, 30 minutes. So don't use pethidine in the second stage. Clear? Now one important drug, fentanyl, is wonder drug actually, 2 micrograms per kg. You can give safely IM or IV. It's a very nice drug. We even use for central neuroaxial blockade. Lesser neonatal depression, which I mentioned in the red color. So maximum you can go up to 100 micrograms, okay. There are other drugs which I don't want to mention here, nalbuphine, butorphanol, it's all available in the market, but we don't advise those drugs. Pentazocine, yes, it is in the, it comes in the name of Fortwin. Tramadol is commonly available drug, doesn't cause any respiratory depression. 50 to 100 milligrams can be given safely. Now what is new? Oh my God, fentanyl. Remifentanil. Remifentanil you can mention in the exams. Remifentanil is a wonder drug. It is ultra short acting. As long you are giving, it works. The moment if you stop that, within 3 minutes, because LOI, lock-in interval, what I mentioned down, within 3 minutes, within 2 minutes, mother will recover from remifentanil. But it's very difficult to procure drug in India. I heard that there are some people using in north side, okay. Now one must remember opioid antagonists. When you are using opioids, sometimes neonates can go in for depression. So you have to reverse the effect. Because baby is already gone for respiratory depression. You can't put the baby on ventilator because parents will get panic. So what you can do, you can use an antagonist and neutralize the effect of opioid. One important antagonist is naloxone, which is available on table. 0.1 milligram per kg is given to reverse the effect of opioid induced respiratory depression. Now what are the advantages of using opioids? Easy to administer, just IV line, inexpensive, no needles. No needles I mean here is you can also use nasal infiltrations also, other than, and you don't have to prick multiple. If you have single IV cannula, that's enough. Avoids complications of regional block. Regional block, I'll tell you, it causes hypotension, reduces uteroplacental blood flow, all that. So which can be avoided with opioids. And it can be administered by a paramedical person also. Nurses can administer the drug if you write and give the prescription. Now what are the disadvantages? Drug goes through the placenta, causes respiratory depression. It is not a complete painkiller. It causes inadequate pain relief because you can't use it for second stage of the labor. Maternal sedation, nausea, vomiting, irritability, and yes, beat to beat variability. See, you always depend on the NST reports. So this causes bradycardia. Opioid causes bradycardia. And if you see neonatal bradycardia, maybe the drug has gone into the baby and caused reduced heartbeat. There is no fetal distress, but it confuses the gynecologist. So heartbeat variability is possible in opioids. So coming to the fetal or neonatal side effects, it reduces Apgar score. One thing, causes respiratory acidosis and neurobehavioral. Normally what happens, there are certain endorphins which are released in the baby's brain during the delivery, which is important for baby to be active and the emotional attachment to the mother, all that. So opioid suppresses brain's baby. Baby is born flabby, drowsy many times, okay. Prolonged NICU stay may be required if you start using opioids. Ketamine. Okay, before ketamine I said sedatives and tranquilizers. Now sedatives and tranquilizers, please note, they are not painkillers. They only sedate, they only reduce the anxiety. And in the beginning picture we saw anxiety is one of the cause for pain. So these drugs what we use as a diazepam or phenargan, midazolam, all reduces anxiety and apprehension in the mother. They promote good sleep and they are the best drug for a mother with hypertension. Okay, and some sedatives do cause antiemetic like Phenergan, okay, but they have systemic effects. So what are the drugs we have on the table? Barbiturates, phenothiazines, benzodiazepines. Now I will not concentrate on barbiturate and phenothiazines. Barbiturate is used for epilepsy, convulsions. Phenothiazines, as already mentioned, with pethidine. Benzodiazepines, we have two important drugs, diazepam and midazolam. I mentioned it in the bracket. Please remember, diazepam has a long acting effect. If you give today, till tomorrow it will be there. If you happen to take sleeping tablet any time, next day morning also you will be drowsy because of the diazepam. It's got a long action. Now what happens, it crosses the baby and causes muscle paralysis. It doesn't paralyze, but it causes hypotonia in the baby. So baby born to a mother who has received diazepam, we call it a flappy baby syndrome. That is the condition caused, and you can always use naloxone here also. Even not only for opioid, even for benzodiazepine you can use naloxone to reverse. Midazolam is an ultra short acting. It acts only for 30 to 40 minutes. 1 to 2 milligrams is the dosage, but this also causes respiratory depression. Ketamine. Ketamine is a wonder drug actually. It is the best analgesic agent, but you have to give in a very low dose, that is about subcutaneous 0.25 milligrams per kg, or maximum you can dilute the drug each ml 1 milligram or each ml 2 milligrams and go about only about 1 ml you give, talk to mother. 2 ml you give, talk to mother, wait for 10 minutes. If the mother becomes drowsy or she talks irrelevantly, stop the ketamine. So the advantage of giving ketamine is ketamine stimulates uterus by sympathetic stimulation. So uterine contractility is maintained with ketamine. But it is a psychomimetic drug. It causes hallucination, dreams. So mother will tell, I didn't enjoy my labor, I didn't enjoy delivery, I was getting my husband dreams in my mind. So it can cause hallucination. Whatever they dream, it comes in the mind. So ketamine is such a worst drug, but it causes laryngospasm, that you must remember. But in asthmatics, it causes bronchodilation. So what are the advantages? Good in asthmatic, it causes uterine contractility, but the disadvantage is it causes hallucination, and at the same time it causes sympathetic stimulation. So automatically heart rate will go up, hypertension will go up. In PIH patients, you can't use ketamine. Okay. Now, where you can use ketamine, you have already, mother has already come to the last stage of the labor, there is no time for epidural or anything. That is the time you can just convince her, I'll give a small injection, you will get sleep or you will get this one, euphoric effect. Or your epidural doesn't work. Some people will say that, and I'll explain, they'll tell it patchy only, you have blocked the nerves, still they say that I have pain, because it's already recorded in the brain. So for such patients, you give small dose of ketamine, they'll be very happy. Okay. So incomplete block or vaginal delivery last stage or patchy epidural, you can use ketamine. Okay. Coming to the neuroaxial block, last technique, I'll not bore you much. There are few techniques I'll try to skip. Spinal epidural, combined spinal epidural. So you are going to place the drug on the spinal cord at the level, it is called regional anesthesia. So we all know that the spinal cord is bathing in the CSF. So you can inject the drug into the CSF or outside the CSF. Outside the CSF, what is there? Dura mater. If you inject the drug outside the dura, it causes epidural. If you inject inside the dura, beyond the dura, it is called subarachnoid. It's central, both comes under central neuroaxial blockade. Now when you do both, sometimes epidural will not work. Spinal has got its own. When you combine both, it's called combined spinal epidural. Okay, very clear? Now what are the drugs we use? We have local anesthetic drugs, opioids and adjuvants. 3 kinds of drugs, local anesthetic, opioids, adjuvants. All the 3 can be combined and given. Okay, and last is mode of administration. If you give a single shot and take it out, it is called single spinal anesthesia, single epidural. Okay, there is no combined single like that. Okay, if you give continuous infusion, the drug will flow continuous. So that is called continuous spinal or continuous epidural. Okay, if you can't give single shot, you can't give continuous. You want to give only when pain comes. It's called intermittent. Okay, clear? Single dose, continuous dose. In between is intermittent dose. Okay. Now, when you want to give, when patient demands, then it is called patient controlled analgesia, PCA. When patient demands, you give patient controlled analgesia. Now you can't sit in labor room and go on when mother demands. So there is a machine which delivers, that is called programmed intermittent epidural analgesia, PCI. Okay? Now what are the advantages? Most effective technique. Believe me, the epidural is going to be the golden standard. Anywhere in the exams you teach your students to tell epidural pain relief is the technique for labor analgesia, because the catheter is there all the time, you can control the pain. This doesn't go to the fetus, it only blocks the segments which is causing the pain. Initially T10 to L1 and then the catheter goes down S2 to S4. So you are blocking only the particular segments, no nausea, no vomiting, no unconsciousness. It is the best technique. And suddenly mother goes for cesarean section, the same catheter you can give injections and convert for cesarean section also. And 10 hours, 12 hours, we have used catheter for 3 days for a knee replacement. Epidural is the best technique. That is why I have put the picture on the right side. Which is more painful, laying egg or delivering? I have not asked a hen now what is her pain, because animals she can't assess. So once you give epidural to the hen also, it will also refuse to give the egg without analgesia. It is such a simple technique, good technique. So everyone must encourage mother to go for epidural analgesia. Now the right side on the blue column, what I mentioned is the latest, what is new. Use low dose local anesthetic, low dose opioids, more volume. Low dose, more volume. That is the technique. Earlier what we are using, high dose, less volume. Now it is low dose and more volume. Why, I will tell you. So this is a picture showing both the epidural and the spinal. Now we have needle in needle technique. Needle in needle technique, what we do is, there is a small eye here. Through the eye, we pass a needle which goes and punctures and delivers the drug into the CSF column. And then the needle is taken out, catheter is passed into the epidural. Single needle, needle in needle, we inject into the spinal and then take it out and pass a catheter for epidural. Now what are the advantages? Uterine perfusion is maintained. It doesn't go to the baby, Apgar score is better, less NICU stay, no local anesthetic toxicity, because you are going to inject small drug on the spinal cord. What are the maternal effects? It blunts the hemodynamic response. So believe me, if your parturient mother who comes for labor is a cardiac patient, hypertensive patient, asthma patient, all of them gets benefited. And lesser catecholamines, no adrenaline, so no burning of calorie or no rise in the blood sugar. So even in diabetics it is beneficial, okay. And there is no depression on the uterus. It doesn't come in the way, but only problem is it can paralyze the muscles, abdominal muscles. It may not come in the way of uterine contraction, but epidural block, if you give in higher dose, can paralyze the abdominal muscles. So mother may not strain. So when you increase the dose, it can paralyze the muscle. So since it's got a lot of advantages, you can use it in case of prolonged labor. So when you give this, it cuts short the duration of delivery in prolonged labor, prematurity, multiple gestation and breech delivery, okay. But you have to avoid using opioids with local anesthetic in these set of mothers. Now when you don't use neuraxial analgesia, this is very important. If you don't remember the use, I am not bothered. But when you should not use, you must know. So we divide these contraindications into absolute and relative contraindications. So indications I have already told. Contraindications, coagulopathy, platelet, low platelet count, infection, local, those with severe cardiac disease, where the fixed cardiac output. Why we should not use in fixed cardiac output? Because already mother is dependent on small cardiac output. The moment you give epidural, it causes hypotension. The moment hypotension comes, cardiac output drops and they can go for pulmonary edema or cardiac arrest. So fixed valvular lesion like severe mitral stenosis, aortic stenosis, don't use neuraxial technique, or you have to go in a methodical fashion. Patients in shock, we know this causes vasodilatation and hypotension. So we are not supposed to use regional technique unless you treat the shock. Mother has got several diarrhea, hypovolemia, don't send her for neuraxial blockade, and somebody with raised intracranial brain tumor coming for delivery, already the brain pressures are so high, you're going to inject 10 ml into the spinal column, so that can throw a fits. So I have broadly divided into absolute and relative. Absolute, no, no. Relative, yes, you can take a chance. Absolute, whenever any patient says, no, I don't want, don't force her. Why? If you force her and she gets into some complication, we have seen even legs getting paralyzed at the time of block. So when mother says no, don't forcefully send her for regional technique, okay? Inability to cooperate. The mother who is not able to sit last minute of the labor, she is not able to sit or she is not able to be quiet. She moves like this. How can you? You can't inject on a target which is shaking. So if you want to use an epidural, you want a calm, quiet, cooperative patient. So that is very important. Increase raised intracranial pressure, don't use. And patient with local infection, don't use, because you can cause meningitis if you take the infection inside. Hypovolemic shock. Now here coagulopathy, I want to discuss few points because we have come across post-corona, post-dengue now. So all your patients will be coming with low platelet counts. So they start asking, my platelet count is 75,000, my platelet count 50,000. Doctor, can I have painless labor? Now the illustration says that 75 is the cutoff point. If the platelet count is 75,000 below, don't subject for epidural. If it is above 80,000, always tell go ahead. Okay? 50,000, don't subject. Now 50 to 80, what you will do? Above 80, you will say no, you will say go ahead. Below 50, you will say no. 50 to 80 platelet count, then what you will do? 1000, I mean 50 to 80 thousands. So then you go and check INR and PT. INR and PT is normal. There is no coagulopathy, only the platelet is low. Then you can tell her to go for labor analgesia. Less than 50, no. Even though PT INR is normal, okay? Now relative, yes, patient has Guillain-Barré syndrome or patient had some kind of backache with a weakness in the leg. Some neurological, still you can take a chance. Mild coagulation abnormality, yes. Relative hypovolemia, small dehydration, she has not taken food or liquid since last night. Give her some IV fluids and send her for labor analgesia. Now this I want to stress for all the examiners, please ask your PGs to prepare this chart in the labor room. What and all things to be kept ready. There should be appropriate consent from the patient. Now once again I'll ask, who has to give consent? Who has to give permission for labor analgesia? Yes, husband, mother, mother-in-law, then patient herself. Yes, this procedure is done in a conscious state. Mother herself is conscious. She has crossed 18 years, so she is eligible to give consent. Any mother demand itself is consent is enough to go ahead with the procedure. Consent, IV line, it should be in the labor room. Examine her for any other abnormalities. Here comes the use of latest gadgets called ultrasound. By doing ultrasound, you will know what is the content in the stomach, whether it's empty or full. By doing the ultrasound, you will know that whether she has got any airway abnormality. By doing ultrasound in 140 kilos, you know where is the spine, where is the epidural. So we use ultrasound machine for all the assessment now. Okay. Now this should be the labor room setup for epidural analgesia. You need to have an epidural infusion for giving the injections, oxygen supply, dedicated machine, ambu bag for emergency. Working suction is most important to prevent aspiration. Suction apparatus has to work. Last minute they can't run that. Where is the suction apparatus? Where is the power point? Where is the plug? Where is the pipe? You can't. Let's keep all the things ready. At the same time, I stress on this NST monitor, because which is very important. The moment you give epidural, there is drop in the heart rate for some time. So NST machine picks up and you can always wait for the mother to progress. So I'll just skip some of these: intermittent bolus, continuous bolus, you all know, I've already explained. Ferguson reflex is most important for all the PGs, so I stress on this. What is Ferguson reflex? Now what happens whenever there is a baby's head pressing on the lower segment causes the stretching of the lower segment, the impulse goes to the brain. The impulse, once it goes, it stimulates the hypothalamus, posterior pituitary and releases oxytocin. Once the oxytocin gets released, it augments the contraction. The more the pressure, more the contraction. So it is a continuous process. You can't block this Ferguson reflex. And second thing, by stretching the lower segment, there is local release of prostaglandins, which causes effacement and dilatation of the cervix. That is another thing. And on the left hand side, I have mentioned relaxin is the hormone which is released that helps in relaxing the ligaments and allowing the birth canal to widen so that the baby's head passes easily. So whatever you do, whatever technique you use should not block the Ferguson reflex. That's very important. Okay, what happens if you do that? There is chances of intrauterine retention or deep transverse arrest. Mother going in for C-sections will be more. Okay. Now some of the injections and the side effects, I'll finish it here itself. Lignocaine, bupivacaine and ropivacaine. Now I was telling all the PGs. Now I tell same thing I want to stress on the teachers also. Please note down, lignocaine comes in 1% and the 2%. 1% and the 2%. And what is 1%? 10 milligram of a substance in 1 ml makes 1%. That we should remember lifelong. Now maximum dose 10 milligram of a substance in 1 ml makes 1%. Maximum dose you can give for a mother is 3 to 4 milligrams per kg. So imagine you have a patient of 70 kilos, 3 milligrams or 4 milligrams will be roughly about 210 to 250 milligrams. Okay, 250 milligrams is the maximum you can give. So how much? I don't know how to calculate in milligrams. Instead let me calculate in ml. So 10 milligrams of a substance in 1 ml is 1%. So you have 1% lignocaine in 1 ml 10 milligram होता है. So 10 ml ले लिया तो 100 milligrams है. 20 ml लेता 200 milligrams. 25 ml is 250 milligrams. So whenever you are giving episiotomy, whenever you are injecting any drug, it should not cross 20 to 25 ml. Is that clear? It's easy to calculate. Imagine you don't have 1%, you have 2%, 20 milligrams in 1 ml. Then you should not cross 10 to 15 ml. Easy? Okay. So lignocaine causes rapid onset, dense motor blockade, it causes muscle paralysis, and lignocaine causes convulsions. Bupivacaine causes cardiac arrest. That is how you have to remember. And ropivacaine is the latest drug which is less motor blockade, less potent, less toxic to the heart, and it is more used nowadays. Ropivacaine and levobupivacaine is the latest drugs which are used for labor analgesia. But lignocaine is always the drug of choice. Now, any drug while injecting, you must ask your PGs, you have to teach your PGs what you have to do, test dose, test dose, test dose. Test, because the catheter you think that it is in the epidural, but we don't know. Catheter might have gone into the blood vessel, or catheter might have gone into the CSF, or catheter might be laying outside. So always you give a test dose to test the drug. So what is the test dose you give? About 3 to 5 ml of the injection, 5 ml of the bolus you are giving slowly, mixed with lignocaine with adrenaline. Xylocaine with adrenaline vial you might have seen. Okay, that comes. Okay, so you take about 3 to 5 ml, give slowly to the epidural. Suddenly the heart rate goes up. That means the tip of the catheter is in the blood vessel. Okay, but when your heart rate will not go up, you are given mother labetalol already. When you block the heart rate by giving mother labetalol tablets for hypertension, you can't expect the heart rate to go up. Then how will you identify? Lignocaine gets into the blood vessel, she will complain of lightheadedness, numbness on the tongue. You can't expect the drug to go to the tongue all of a sudden. So that means that drug has entered the intravascular, it is going to the brain. Next if you give, you shall throw convulsions. Okay, that's one thing. And second thing, you are given injection. While giving in 3 ml dose, you ask mother whether she can lift her toe, great toe. She says, no, I can't lift, it's already paralyzed. The smaller drug causing paralysis, what happens? Your drug has gone into the spinal column. So don't go for second bolus dose. So always give a test dose and ask the mother to watch on the legs are getting paralyzed. Okay? Now for the PGs, so choice of local anesthetic, whatever the local anesthetic you choose, it should be longer duration of action, it should not cause motor blockade, it should increase the uteroplacental blood flow and minimal toxicity. These are all the effects should be there, whatever drug, local anesthetic you choose, okay? So coming to the intrathecal opioids, now what happened, we started analyzing epidural will act for a long, it takes time to act, onset of action. So we started doing puncturing the dura and then injecting the drug in the epidural space. You understand? Puncturing the dura, because the drug which is placed epidurally slowly passes through the hole and gets into the CSF column and blocks. Onset is fast, prolonged duration. So dural puncture and epidural analgesia. That is another technique which is latest. So we are earlier using a concentrated drug. When you use a concentrated drug, the side effects are more, and you want T10 to L1. So normally it is calculated in such a way that 2 ml of the drug is required for one segment. So T10 to L1, T10, L1, L2. Okay. So you want to block 3 segments, at least 2 ml means 6 to 10 ml is minimum epidural drug required. So if you take 6 to 10 ml of local anesthetic, it will be more. So rather what you do, you take 2 ml, dilute it to 6 ml. That is the reason I said 0.125. You see 0.0625 or 125. 0.25 if you dilute further, no, it becomes 0.125, 0.60625. So you have to make 4 times dilution. So that is the lowest concentration, highest volume. Okay? Clear? Opioid, if you want to use only opioids, you require a larger dose. It causes neonatal depression. Speed of onset is there, but epidural opioids alone cannot be used. It should be always mixed with the local anesthetic. Now the disadvantage, as I mentioned, prurite itching, hypotension, neurotoxicity, respiratory depression and delayed gastric emptying. Okay. Now I was talking about the cardiotoxicity. The moment you give bupivacaine, cardiac arrest can happen in the mother. So what you do when such a thing happens? You have to resuscitate in the labor room. Best drug is the lipid infusion, lipid emulsification. So in your labor room there will be a drug called propofol, which is nothing but the lipid. When you give lipid, this goes and binds the heart fast and prevents the local anesthetic binding to the heart. So immediately you have to push the lipid infusion or propofol and do CPR to save the mother's life. So always keep the emergency gadgets ready, like 100% oxygen, ambu bag, and don't lose your hope. Give CPR for some time. Definitely mother will come back, because all these drugs are shorter acting. It will get released from the heart. It only blocks the heart for some time. If you can do resuscitation, if you can do CPR, cardiac massage for about 5 minutes, 10 minutes, we can still revive the mother. So don't lose your hope. On a table in a labor room, if you come across such an event, keep all these gadgets ready and then resuscitate. Okay. These are the drugs. Now the fancy thing is walking epidural. Everyone starts talking about this ambulatory anesthesia, walking epidural. What is this walking epidural? Now epidural, I was telling, low dose, high volume. When you give low dose, high volume, it only blocks the nerve impulse which are carrying the pain. It will not cause paralysis. So you want mother not to have a full bladder. In between, we allow mother to walk in a vertical position. She can go to toilet without causing paralysis. Theoretically speaking, yes, but practically speaking, we don't take chance, because sometimes they will not have sensation in the leg. So they may slip and get fracture or anything. So we don't advise mother to walk freely, but there are some institutions under proper monitoring, they do this walking epidural with a low dose, high volume, blocking only few segments. Okay? Because you know that the legs are supplied by what dermatomes? L, 3, 4, 5. We are going to block T10 to L1. So T10 to L1 is only abdomen you are blocking, not the legs. So leg power is maintained. So mother can go to the toilet or walk. For that you have to check for the reflex, and there should not be any postural hypotension. So if there is a postural hypotension, she can go for cardiac arrest. Okay. Now what are the advantages? When you block this, there is less chances of deep venous thrombosis, upright position, chances of delivery, less cesarean section, faster progress. Okay. Now what should be the criteria for mobilizing the mother? There should not be any maternal or obstetric contraindication, or cardiac problem should not be there. Okay? And there should not be motor blockade, and there should not be any opioids. And always check with the supine and sitting, you have to check the blood pressure. If it is less than 10%, you have to check the mother's blood pressure in lying down, make her sit and then recheck. If it is 10% less than the previous reading, don't allow mother to walk to the toilet because postural hypotension. Okay? Other than supine hypotension syndrome, mother can also have a postural hypotension. Indications, which are the patients you want to give? So medical indication, hypertensive patient, cardiac like what I spoke, diabetes, asthma, and then obstetric indication whenever there is a prolonged labor. Many studies have proven that by giving epidural you are cut shorting the duration of labor. Okay? And same analgesia can be continued for C-section also. And whenever baby has got a prematurity, breech presentation, where you don't want to take chance, you can always plan epidural. Now, when do you place epidural catheter is a big question. You always ask your students. When you want to, कल डेट है तो आज ही आके डाल के चले जाओ, एपिड्यूरल रख के घर में घूमता रहे, कल सुबह आ जाओ, देखते हैं. Suddenly I can't because anesthetic is not available. No, अभी free से बैठा है, डाल दो catheter करके. No, we can't do that. When you put catheter, last time I told this incident. I had a patient where mother happens to be a criminal lawyer. So she came for delivery. I put the epidural and they says, नहीं कुछ नहीं हो रहा है. I'm moving my leg. I'm having pain. Because you must tell the mother that there are two events happening in the delivery. One is contraction, other one is pain. Contraction आता है, pain आता है. When you block that, contraction आता है, pain नहीं आता है. You must tell them. They think that contraction is pain only. She was telling, अरे क्या anesthesia दिया यार? I am feeling it's very hard, tight. I am having pain. Why don't you understand? What I can do that time? Because I had put epidural catheter, she didn't realize what is pain. If she had suffered some pain, then I had put, then she would have appreciated me. You understand? Later what I did, I gave extra dose and paralyzed her leg. Then she accepted, yes, ये काम कर रहा है. So you have to think when you want to give. So when any mother comes and demands, I can't tolerate pain, wait for onset of the contraction, onset of the pain, low back aches, beginning, early first stage, you can place the catheter. For that, some people will come simply with false labor pain. Then you can't put catheter until after 10 days, no. So you have to wait for the cervix to dilate at least 3 centimeters. So when cervix dilatation is happening, pain is coming, that is the time you know that she is progressing. Already pain is there, if you block, it has got some value. Okay, clear? Now if your patient is cardiac or respiratory, yes, well before you can plan. Obese patient, because last minute when they go for pain, you can't make them sit and slowly cooperate for giving epidural. For such patients, yes, you can put it early, but not one day before, on the day of delivery. Now big question, there are a lot of questions will be asked to the obstetricians. We have seen many patients after putting epidural, mother going in for temperature. Now why you are all bothered about temperature? Maternal temperature can cause fetal adverse outcome. Baby can be born with mentally retarded later, or baby can be born with poor milestones, all that. Why fever comes? We started thinking whether infection or inflammation. What is the problem? Now there are different mechanisms said. Once there is vasodilation, that there is a dissipation of the heat. So that is felt in the form of raised temperature in the mother, and there are certain interleukin 6 is released which causes epidural fever. There is no raise in the total count. So this is not an infective condition. You need not start an antibiotic in such cases, thinking that mother is having temperature, maybe baby will also go for sepsis. We have done CRP test in the newborn babies. The CRP is not raised, so it is only epidural fever possible during the labor analgesia, which you must explain to the mother and the pediatrician. I'm sorry because of the short of time. I just wanted to show you the needle through needle by the side of the needle. So there is an eye in the needle through which we go and do combined spinal and epidural. Now why your epidural fails, I have an answer here. So when you pass a needle might have dented the dura, it has not gone beyond, or it is just lying in the subcutaneous space, or the needle might have gone away from the dura. So whenever such thing happens, the block is not working, you must ask the anesthetist to repeat the procedure and redo the procedure. And whenever there is a patchy anesthesia, mother will tell only half of the body I am not able to feel pain, other half there is a pain. That means the catheter has gone to one side. You can only remove the plaster and pull about 2 centimeters back so that the catheter comes in the midline. Then you can allow the drug to flow. Now there are enough studies to prove that was there any risk of cesarean delivery following the neuraxial analgesia? You must say no, because this is a good study. It says that it cuts short the duration of labor and there is no incidence. The incidence of C-section is common in patient who has received a neuraxial block and patient who has not received neuraxial block also. So what are the myths? These are the doubts your patients come to you. One is C-section, other one is prolonged delivery, instrumental delivery. Yes, there are some people started telling when you block the nerves, mother will not push, so I have to put forceps, ventouse, all that. No, there is no such studies to prove that there is increased instrumental delivery. What about later backache? Backache can come to anybody. It is not because of the technique as such. You must tell them there is no. Suppose you have done spinal analgesia, post-spinal headache. Yes, you can ask mother, you can tell that headache is possible, but it's only for 2 days it will come down because of the CSF leg. And effect of the baby, nil. Okay. Now coming to the regional last 2 technique, paracervical technique, paracervical block. You know the cervical dilatation is causing the pain. So why don't we block the cervix by using paracervical block? So please note that paracervical block works only for first stage. Second stage there is no cervix. It is taken up, dilated, so you can't find any cervix there. So here we have inject about 5 to 10 ml. And note down the position, it should be done at 4 o'clock and 8 o'clock, not at 3 o'clock and 9 o'clock, because thick cervical venous plexus are there. The moment you inject that drug, most of the medicine, instead of going into the subcutaneous, it will go into the intravascular and cause convulsions. So 4 o'clock, 8 o'clock position should be there. So this is the picture showing. Now what are the complications? The moment I have seen sometimes gynecologists while giving paracervical block, they put the needle directly into the baby's head and injected the local anesthetic into the brain, baby's brain. So you should always keep your finger under control. Where is the tip of the needle is going? It should always touch your tip of the finger, and there is an introducer. Nowadays it has come with the introducer. You introduce, it goes only through the introducer and injects and comes back. Otherwise your finger will be here, needle will go into the scalp. So after injection we have seen fetal tachycardia and postpartum neuropathy. Sometimes they will say that one half perineal they will have numbness. Okay. Now this is one fantastic way of blocking pudendal nerve block. How it works, we know that the sacral nerves comes through the sacral foramina S2, 3, 4 and it passes close to the ischial spine. It passes very close to the ischial spine and then enters the obturator foramen along the lower margin. It just comes and supplies the perineal region. So through the inferior pudendal branch of perineal. So pudendal branch, all gynecologists are familiar of while doing PV, you adjust CPD by looking at the ischial spine. So this nerve goes very close to the ischial spine on the sacrospinous ligament, go just medial to the sacral spine and inject inferiorly about 5 to 10 ml. So you are going to block whole perineal region in the second stage. So please note down, pudendal nerve block second stage, cervical block first stage. Okay. This is the technique. You keep your finger close to the ischial spine, feel for the ischial spine, guide the needle along and then inject the drug. This blocks only S2, 3, 4, not the T10 to L1. Clear? Now what is the recent advances? So we went through some of the literatures. Now earlier the oxytocin dose we were using about 10 units bolus at the time of, this is I am talking about the C-section or after the delivery or during the delivery, not before. Now the latest rule is rule of 3, where you use the 3 units of oxytocin, 3 international units at 3 frequency, so given every 15 seconds. Okay. assessment of the uterine tone, not the earlier what we are using. Why? Because they started studying high dose oxytocin, low dose oxytocin. Whether you give high dose or low dose, whatever the receptor is there, that much only it can bind. So the effect is same. Instead of causing oxytocin toxicity, you start using high dose of oxytocin. Every chances of mother going in for atonicity is there. So use low dose oxytocin to prevent postpartum hemorrhage. Okay. And to prevent incoordinate uterine contraction. Sometimes excess oxytocin also causes incoordinate uterine contractions. Hemorrhage. See, rule of 3, you use 3 doses of oxytocin, 3 units, 3 international units at the interval of 15 seconds. No, you can put infusion. In 15 seconds time is there, no, slowly you can run, no problem. Either you can give or you can go for this. I am talking after the second stage. I am not talking before, after delivery, not at the time of labor, okay? Yes. 3 units of international units, 3 doses at the rate of 15 seconds. Then followed by 3 international units per hour infusion. He used to give 10 units bolus or 20 units to the bottle and you don't know what rate it is running. So you slowly concentrate the receptors and allow the uterus to contract. So if you give during the labor you have used a lot of oxytocin, it may not work at the time of PPH or other. 15 seconds you can go in any dose. Either you can dilute in 5 ml or 10 ml. They don't mention what volume you have to dilute. But 3 international units per hour should be the infusion rate after the bolus. Basal and bolus dose. Okay. Maternal hemorrhage, yes, be prepared. Maternal hemorrhage. Now here, what you do when there is a maternal hemorrhage? We have started thinking that if it is less than 30% of the blood volume, normally we don't assess. One place where we miss the bleeding is in the labor room. Okay, labor room, we don't know how much of blood has gone. So you see that the volume is the number of mobs, or if you have measured, if it is 30% of the blood volume, less than 30%, you can always replace it with crystalloids or colloids. If it is more than 30%, then no option, 1:1:1. For every 1 ml loss, 1 ml blood has to be given. Now there is, the latest rule says you can use 1:1:1. One is 1 packed cells, 1 FFP, 1 platelets. I always ask questions, instead of getting 1 packed cell, 1 platelet, 1 FFP, it's so costly, give 1 bottle of fresh whole blood. But there is something called TRALI, transfusion related acute lung injury, TRALI. Transfusion related acute lung injury, there are some leukocytes, white blood cells in the whole blood which causes lung damage, ARDS. Blood reaction is more while giving whole blood. So why you want it is, they have already separated and kept safely, go on infusing it. Okay, this one study says that fibrinogen or tranexamic acid. So what use? The latest study says that the tranexamic acid is the wonder drug to prevent the blood loss. If you suspect that the mother is already on heparin, mother has got low platelet count, you can give 1 gram of tranexamic acid 3 hours for PPH. Okay, maximum up to you can go for 3 grams in a day. Each ampule comes as 500 milligrams. 2 such ampules you can give up to 3 grams. This reduces death and reduces blood transfusion. It is proven even in cardiac surgery also. Okay, fibrinogen is very costly, but when you give, when there is a coagulopathy documented, tranexamic acid is only for capillary bleed, not for coagulopathy. Whenever you come across coagulopathy, you have to use fibrinogen. So to summarize, first stage is cervical dilatation. So you can, what are the techniques you use? Cervical dilatation. And second stage, first stage systemic medication, second stage volatile gas, epidural will act both first stage as well as second stage. Okay. So when you are answering exam, what is the method of choice? Always say first is epidural technique, and if you don't have an option, first stage you can always tell them I can give paracervical block, I can give systemic medication like pethidine and Phenarga and all that. Second stage, pudendal block or inhalation anesthesia. So the key points to end the talk: continuous epidural infusion, patient-controlled epidural analgesia is the technique, but it can affect the fetal heart rate and confuse the gynecologist. Labetalol does not make any change in the heart rate. Dural puncture may improve the quality of the block. So assessment of airway by using ultrasound is the latest technique. Phenylephrine is the drug of choice if you come across hypotension. Lower dose of oxytocin is best comparing to the higher bolus doses. Fibrinogen concentrate is recommended only in the coagulopathy with obstetric hemorrhage, PPH. Tranexamic is a wonder drug to prevent postpartum hemorrhage. To summarize, labor analgesia is a woman's right, no one can block them. So lumbar epidural is the golden standard. Low dose with opioids is the best technique, and of course good teamwork. Unless gynecologist sends, we can't block the nerve. Don't go to that fellow, you will put epidural directly. You can't. Unless your cooperation, it doesn't make. Good teamwork, pediatrician, gynecologist, nurses, everybody should be there. Now, can you raise the hands? I just want to see how many are awake still. Oh my God, now everyone is raising. Because I'll catch, no? So we'll have 1 or 2 case studies to close the talk, if you don't mind. 22-year-old primea gravida comes with full-term pregnancy with a labor pain. She is a primea, young age, not elderly, 3 centimeter dilatation. Patient was diagnosed to be suffering from rheumatic heart disease, heart problem, 2 months pregnancy. When she consulted cardiologist, there is a progressive dyspnea on exertion. She cannot walk also, she gets breathless. How will she cooperate in the straining? Okay. Echo shows ejection fraction 46%, good heart pumping, heart rate is normal 90, blood pressure is normal 125, 78, respiratory rate is 24, oxygen saturation is 95. There is no asthma, there is no heart problem, there is no hypertension, but she has a heart problem. She has come at 3 centimeters cervical. What is your choice of painkiller? Epidural. That is easiest answer. You throw 10 stones, it will hit one tree, one mango.